question from Fabi on Instagram. Can ultrasound images show everything is fine, but once you get inside, can be a different story? Absolutely, yes. Ultrasound and MRI could be completely normal, but then we do surgery by laparoscopy, video laparoscopy, and we find from stage 1 to 4 endometriosis very often. Absolutely yes, MRI and ultrasound do not always show endometriosis, and I recommend you read a paper we published in the Journal of Clinical Medicine, January 2024, this year. This is a free download, and incidence of endometriosis in patients with unexplained infertility. These are patients that ultrasound was normal, MRI was normal, all the tests normal, the partner, everything was normal. When you scope the patient, more than 90% of them had endometriosis. This is a very important question, Fabi, that you are asking. We are going to show you again for Journal of Clinical Medicine, January of 2024, and you can see the incidence of endometriosis. Also, the same journal, Journal of Clinical Medicine, there is an app we published. It is validated for diagnosis of endometriosis on patients who have infertility, highly accurate, Fabi, that this app again was published in the Journal of Clinical Medicine. You can see that, and we are going to put it on the program here for you. You can easily, freely download it. There's also a question from Elizabeth on TikTok. How risky or hard is it to remove endometriosis from the nerves? Endometriosis surgery at time could be much harder than a cancer surgery, so it should be done by very experienced surgeon. And every surgeon, even every endometriosis expert, doesn't have expertise to treat endometriosis of all the organs. Like and endometriosis specialists might be experienced to treat some part of it, but not all part of it. So it is important that you deal with an experienced surgeon who is able and capable to treat very thoroughly the disease. Thank you again for asking your questions, and forward we go.
Hi, my name is Namira, and I founded Endometriosis, Singapore's first accredited endometriosis support movement. Our goal is to educate, advocate, support, and provide proper channels for matters relating to endometriosis. Firstly, I would like to express my gratitude towards the worldwide EndoMarch team for your exceptional efforts in organizing a stimulating and wonderful event every single year. Your dedication to planning and executing this global movement has left a lasting impact on me. So thank you for your unwavering commitment towards raising awareness about endometriosis and for providing a platform for individuals around the globe to share their experiences and insights. As well as to Dr. Kamranazar, your commitment towards advancing the field of medicine and improving the life of those affected by endometriosis is truly admirable. The movement is that endometriosis started getting involved way back in the pandemic year 2021, if I'm mistaken, and that was through an email that I sent to Barbara, and from there on we have been committed into making endometriosis awareness loud and about.
Okay, that was really nice. So if you like, do you want to add something, or
Allow me to provide you with a brief overview of the origin of the E for Endometriosis campaign. So in 2012, E for Endometriosis began as a personal blog. Over time, it evolved into an educational platform that strived to pave the way for greater understanding and acceptance of this condition. With its unwavering commitment to promoting knowledge and compassion, E for Endometriosis serves as a valuable resource for those seeking information and support in the face of this challenging disease. And this makes it Singapore's first endometriosis awareness movement, hence the slogan paving the way. Now, it was finally ACRA registered. It's an accreditation in Singapore in 2017. So the following month, the Facebook group page known as Singapore Endometriosis Support Group was set up. And this is upon receiving encouragement from Bati, a retired nurse specialist at NUH, as well as Dr. Mali, an accredited aubergine specialist who runs the endometriosis clinic in NUH. Now, the purpose of establishing the Facebook page itself is to offer a secure environment for those who are impacted by endometriosis. The page aims to foster a community of individuals who share similar experiences and challenges, and it is envisioned as a platform where people can connect with each other, exchange ideas, and obtain support and guidance from others who can relate to their struggles. So, following in year 2021, we received sponsorship, hence we launched our website, endosupport.sg, coinciding with March Endometriosis Awareness Month. And as the year progressed to 2022, now that marked a decade since our establishment. So we took the opportunity to commemorate our 10th anniversary. And in the subsequent year, 2023, we hosted Singapore's first physical event post-pandemic, which is this year, 2023, which centered on endometriosis. And the event is called the Wear Yellow SG EndoMarch 2023. And this event was entirely run by volunteers, most of whom were endo warriors. So participants were encouraged to wear yellow to show solidarity towards the cause. And a member of parliament, Ms. Carrie Tan, graced the event as our guest of honor. The event featured a film screening, which served as an impactful way to raise awareness and educate the public about this debilitating condition during Endometriosis Month. Actually, I have prepared snippets of that event. If it's all right for me to share, or
of course.
If it makes you nervous, it's probably worth it. Why save it for sleep when you could be living your day deep? 31 waiting tables. She has a voice of an angel.
Here today is the first time you're getting to know Endometriosis.
She only sings in the shower. All these things we say will get you shot down by the reasons not to.
The more the merrier, the more people do something to share.
Don't quit your daydream. It's your life that you're making.
So she's been amazing, but I think sometimes she deserves a bit of a rest. So if everybody can help lift the load a little bit, I don't want to lift the load.
If it makes you nervous, it's probably worth it. Why save it for sleep when you could be living your daydream? So scared of failure that we fail to try, turning around before the finish line.
E for endometriosis.
So daydream.
yeah, so that's the video.
Nice. Like, for me, this is one of the most important things, becoming like advocating and just sharing your stories and listening to the others, of course, at the same time, to stand up for someone who can't share, who can't just standing up for herself or like himself sometimes. So it's really nice.
It's really heartening when you see people come together for such a cause.
Yeah.
Especially, endometriosis can be such a lonely journey, which due to the stigmas and taboos surrounding it, right? So we have oftentimes feel that we are being dismissed. So to have such an event is powerful and impactful, especially to know that you are not alone in this journey. And that has been a trademark to E for endometriosis. This is actually the alphabet E, if you can see E, which stands for empower, embrace, encourage, and of course, endometriosis awareness. Now, these three keywords, I believe, are the pillars of understanding the disease and advocating about it. Empower with knowledge, embrace the change, and encourage conversation. So, probably we can try and make it viral. So whenever you take a photo or video to create endometriosis awareness, maybe you can add the E sign. You just need to use your right hand to show the E, and then you can hashtag E for endometriosis. It has to be right hand. If it's left, and it becomes something else. So right hand, okay? Right hand, yes.
Can you please tell us about what changes do you think are necessary on behalf of Asia or Singapore? Like, if you want to share something about that, we would like to listen.
Sure. Perhaps I will just share the situation with endometriosis or women's health, or even in general, the situations with endometriosis here in Singapore, largely Asia as well. So being a country which is still laced with conservative societal disposition, the movement is slowly approaching the topic by first campaigning about menstrual health. So we have to approach it slowly. Now, E for endometriosis seeks to provide much needed support and assistance to those struggling with menstrual health, while also raising endometriosis awareness and promoting greater understanding among the general population about this disease. So we cannot approach it hard and straight away with what is endometriosis. Rather, we have to approach it slowly due to the environment or the situation with our country. So despite the challenges posed by the prevailing cultural norms, we remain steadfast in our commitment to improving the life of those affected by these often overlooked health concerns. So what are the few challenges we face here in Singapore? Pretty much similar to the rest of our counterparts: shame, stigma, and misinformation surrounding menstruation contribute to this ignorance. So this results in serious health consequences of such issues, as well as of menstruation, including menstrual disorders, which are often neglected. So let me just quote an article from Channel News Asia, entitled "More Women Diagnosed with Endometriosis Amid Greater Awareness of the Impact of Severe Period Pain." Now, this is dated 10 of June 2021, and Associate Professor Fong Yokifai from Singapore Medical Group mentioned that awareness is sadly lacking among the general population, among doctors, and even specialists themselves. Many get dismissed even when they get to the GP for a pain injection during their menses. Some are told it's all in the head or to just accept it. Others are even told by specialists that it is normal. So raising awareness about endometriosis also involves challenging centuries-old stereotypes about women. As long as we are normalizing this prejudice, the silencing of our women's health in this area continues. And if these painful symptoms are dismissed as primary dysmenorrhea, then a doctor won't investigate further. Diagnosis and timely management of symptomatic endometriosis. There is still a very low recognition of endometriosis at general practitioner level, where young women usually go with their painful symptoms. But how to combat ignorance as such, right? I strongly believe, and if that if each and every one of us effectively manage our health, we have to also take ownership of our healthcare and engage in open discussions. It is only through this open discussion and proactive approach, it will not only empower us to take control of our health, but also helps to remove the stigma surrounding this disease and encourage others to do the same. So it has to start with a conversation.
So in that point, you mentioned about healthcare system, and they encourage actually people about endometriosis. And if you want to compare the last years and before, is it like more easy to find endometriosis specialists in the Singapore right now, or like, can you compare the then and now in terms of the endometriosis specialists?
Sure, when it comes to endometriosis specialists compared to when I was diagnosed 10 years ago compared to 10 years after, right? So 10 years ago, the word endometriosis is still such a foreign topic. It is unheard of, let alone have finding a specialist that is able to properly diagnose us with endometriosis. It took me quite a while. I had to go through from one specialist to another specialist and to just get myself properly diagnosed. Yes.
Change countries for that or something like?
It's still within the country itself. I was lucky at that point of time. There was an endometriosis specialist, Dr. Peter Barton Smith, who was around in Singapore back in 2014. Well, that was many years ago, right? So it was only when I met him that I understand what endometriosis is all about. Because previously I met a specialist, I had fibroid removed, polyps removed, I had some surgical procedures done, but it doesn't, lighten the issues that I'm facing. It's only after I met this specialist, endometriosis specialist, that I was able to really understand the condition that I'm suffering from. Now, fast forward 10 years after that, after Dr. Biderman Smith has also awareness on endometriosis, after I have established this movement, more and more women are finally realizing that there is such a disease. Yeah, and especially more that women are finally realizing that one of the symptoms, which is dysmenorrhea, is not normal. Because we will brush aside as it being normal, and then for us needing to take care of the family, we don't really do much of our health, and then we just ignore the symptoms. So I would say there is a change. Of course, we have to we do require a lot more changes to come. Well, for specialist-wise, we are still severely lacking. There is a few that I know of that is able to do the task, but when it comes to managing deeply infiltrating endometriosis, now that's very tricky, right? You have to at least have around more than 1,000 surgeries to be qualified as someone that is capable to be a specialist on that area. So I would say we are still severely lacking here. There are a few that is credible, but awareness has to be continued on for us to finally have the change that we want holistically.
So if there is anything you want to share with us or with the audience?
Oh, sure. Okay. Right. Maybe I can share a little bit of, sorry, you were saying?
Maybe there are like some ongoing projects of yours you'd like to
Oh,
share.
yes. Ongoing project for 2024 where Yellow SG is, yeah, we are still on planning it. Definitely, we are going to proceed with it. We are going to make it an annual event.
That's
So
nice.
so yeah, well, Yellow SG, yeah, basically we will be, getting specialists to talk about some issues pertaining to endometriosis. We're still trying to get probably other expertise, and same as the years before, we'll try to get expertise in like a nutritionist or as well as other areas that would benefit sufferers, because we also know that endometriosis is a lifelong condition which you need to manage. So definitely this is in our pipeline. So very excited for the year to come. And perhaps I would like to add on, probably to end this off. Again, thank you everyone for being such a sport, the team. You are all brave warriors, and it is an honor to be part of this community. Thank you for having me. Just to inform everyone here, just to let you know that on most occasions, just like yourself, Alif, I am also a one-woman army dedicated to bringing together those who are struggling with painful effects of endometriosis. So through creating a secure and inclusive platform, I aim to provide a safe and supportive space for women to connect, share experiences, and seek guidance. I hope to expand my efforts and make a meaningful impact on the lives of those affected by this debilitating condition. So do subscribe us as well over here to details, right?
Yay.
And it's all there. Yeah, so you can also check our previous talk stream live on the Movement's YouTube channel, E for Endometriosis. Now we have past speakers, includes clinical psychologists, nutritionists, fitness instructors, fertility specialists, and more. So we have shared their expertise. So do check out. Hopefully, it will be beneficial for you as well. And just a reminder, one voice has the power to change the world. So no matter how small it may seem, even if you're a one-woman army, do not be afraid to claim your narrative and amplify your voice. Be the catalyst for change by taking a single step forward today.
Thank you so much.
I can definitely relate to you, Elif. So that's one especially for you, coming from my heart.
Thank you.
In this video, we present a robotic total hysterectomy, bilateral salpingo oophorectomy, and sentinel lymph node mapping for a patient with endometriosis and concurrent endometrial complex atypical hyperplasia. The patient is a 50-year-old G0 referred to gynecologic oncology for management of complex atypical hyperplasia noted on dilation and curettage for an endometrial polyp. She reported irregular cycles for the past year associated with dysmenorrhea, dyspareunia, and bloating. Her pelvic ultrasound was significant for an endometrial lining of 9 millimeters, with an endometrial polyp measuring 6 millimeters. She had a posterior body subserosal fibroid measuring 2.5 by 2.1 by 3.3 centimeters, and a left ovarian endometrioma measuring 3.6 by 4.4 centimeters. Her past medical history was significant for anxiety, depression, asthma, and migraines. She was on sumatriptan for management of her migraines. She was counseled on management options for complex atypical hyperplasia and agreed to proceed with total hysterectomy, bilateral salpingo-oophorectomy, and sentinel lymph node staging for possible up to 40% risk of concurrent malignancy. She was taken to the operating room where laparoscopy revealed fibroid uterus with a dominant posterior fibroid and bilateral ovarian cysts with severe endometriosis and adhesions to the pelvic sidewalls. The right pelvic sidewall was opened and dissected for sentinel lymph node mapping using indocyanine green dye fluorescence, which was injected into the cervical stroma to highlight the lymphatics. The sentinel lymph nodes were dissected and excised for staging. An aberrant obturator vein was encountered and isolated during the dissection. Here we can see the right aberrant obturator vein highlighted in blue posterior to the pelvic lymph nodes. More medially, we can see the obliterated right hypogastric artery highlighted in red. After the underlying structures were identified and isolated, lymphadenectomy was safely performed. Attention was then turned to the left pelvic sidewall, where the left pelvic sidewall peritoneum was similarly opened and dissected for left pelvic sentinel lymph node mapping. Here we can see the left ureter highlighted in yellow. And here the left medial umbilical ligament can be seen exposed as the distal portion of the hypogastric artery continuing infero-anteriorly. Pelvic sidewall was further dissected to identify the left external iliac artery and vein as highlighted here. Left pelvic sentinel node lymphadenectomy was performed similarly using indocyanine green dye fluorescence for mapping. Attention was then turned to the hysterectomy and lysis of adhesions. Dense adhesions and deep infiltrative endometriosis were noted between the left adnexa, pelvic sidewall, and sigmoid colon, which were carefully lysed. On the right side, the right IP ligament was identified, carefully skeletonized, then cauterized and cut for oophorectomy. After left oophorectomy was similarly performed on the opposite side, attention was then turned to the sigmoid colon for further lysis of adhesions and treatment of endometriosis. Dense adhesions and deep infiltrative endometriosis were encountered in the posterior lower uterine segment with an obliterated cul-de-sac. Adhesions between the rectosigmoid colon and uterus were carefully lysed using a combination of sharp dissection and judicious use of cautery. Next, the bladder flap was carefully developed. The uterine vessels were skeletonized, cauterized, and cut on both sides. Colpotomy was then performed around the uterine manipulator cup for a total hysterectomy. The specimen was placed in a bag and removed through the vagina. The vaginal cuff was closed using a barbed, absorbable suture in running fashion. Estimated blood loss was 100 cc's and patient was discharged home the same day. Final pathology revealed a 240-gram uterus and complex hyperplasia, multiple leiomyomas, and adenomyosis. Lymph nodes were benign. Left fallopian tube and ovary revealed benign findings with endometriosis. Right ovary also had endometriosis. Additionally, endometriosis was noted in the biopsies collected from right and left uterosacral ligaments, posterior cul-de-sac, right round ligament, right pelvic peritoneum, and right parametrium. Thank you for watching.
Thank you, Dr. Najat and audience. It's a pleasure to be with you to discuss recognition of endometriosis And will markers help us with this in the future? My disclosures are listed in the 3-page AAGL conflict of interest paper that I have. If anyone needs it, it is available on request. One thing to realize is that I was a reproductive surgeon. My money was made doing surgery. I retired on investments from that. I have a bias towards surgery. I'm going to conclude that you should consider routine transvaginal sonography on patients scheduled for laparoscopy for pain. Consider MRIs if your radiologist likes those better than sonography. If you're doing adolescents, be ready for lesions that are 0.2 millimeters or smaller. And if you have a palpable nodule, repeat palpation after you've removed it. Regarding the biomarkers, surveys, apps, and other things that are useful in tertiary care, we're still waiting to see what those will do in primary OBGYN, pediatrics, emergency room, and other centers. They need to be validated in each of those before we know if they're useful in those. These do need to be part of any comparative research project that is being run at present. At a clinical level for primary OBGYNs, as always, you need to be prepared for change, as if nothing else is constant, change is. If these are useful in low-risk patients, you may need to incorporate them. As Donna Vogel said in 2000, studying endometriosis is like nailing Jell-O to a tree. This is not to underestimate the pain, neglect, normalization of pain, and the other challenges that patients face in everyday life. Those are very important, but today's conversation is on what do we miss and what can we do better. We're going to review the difficulties and techniques related to recognition of endometriosis, look at our limits, and try to determine how do you balance goals that include pain relief, restoration of fertility, completeness of procedures, avoiding complications, and avoiding recurrences. I've listed 16 different ways you can miss endometriosis here. There's more than those that are covered in my Endometriosis Concepts and Theories paper on pages 13 and 15 at the link below. For those of you who are interested in this topic on doing recognition, I would encourage you to read those 3 pages. They're at that link. I'll have that link at the end of the paper again, if you want it. The earliest finding of missed endometriosis was ovarian endometriosis. In 1899, William Russell published a paper that included aberrant portions of the Mullerian duct found deep within an ovary and hidden behind adhesions, and an adherent but otherwise normal ovary on the right while doing a left cystic adenocarcinoma. More recently, similar findings have been found by Candiani et al., who had 52 women with enlarged ovaries but no evidence of cyst at laparoscopy. They did aspirations and aspirated material from 48% of those. 21 of those had an initial revised ASRM stage of 0 because they had no evidence of other endometriosis, and afterwards were upstaged in 8 because with an otherwise normal pelvis, they did make the diagnosis based on the aspiration. There is somewhat of a limitation, as only 3 of these cases had endometrial-like epithelium demonstrated on histology. But ASRM OOs also happen in the sigmoid colon. This is an example from about 1986. The reddish lesion is the only visible endometriosis we found. Behind that small reddish lesion of about 5 to 10 millimeters in size, there was a 2 centimeter fibromuscular nodule within the bowel wall. You can see in the schematic the relationship, that small polyp with a reddish little polyp on the surface, the deep fibrotic nodule. Then on histology, glands and stroma and edema in the surface, and a deep fibromuscular nodule behind that. Visualized, we at least had something going for us there, so we knew that there was something in the bowel, but there are also non-visualized ASRM-00s. Between 1984 and 1996, over 12 years, we had 3 patients with up to 20 non-visualized but palpable nodules at laparotomy. Laparotomy was necessary to make this diagnosis, and therefore it made it difficult to continue doing these, with only 20% of 15 who had persistent GI symptoms, or 0.2% of the total of 1,588 endometriosis surgeries in that 12 years. This became an issue more recently when Baduscu et al. Reported up to 33 satellites in bowel resections when doing a step section through the bowel on specimens. They found that 100% of patients had those satellites at up to 5 centimeters from the primary, and 4% had them as much as 5 centimeters from the primary. Since some of those were up to 10 millimeters in size, that group did a subsequent study and found not that some of these were still not visualized, but they were palpable. So the 51 patients in this study, 13 had non-visualized palpable satellites of 2 to 10 millimeters, with 7 of those patients having them past the otherwise planned staple line, and the surgery was extended to be sure to include all the palpable nodules. Without that, there would have been nodules left behind, and some of those may have resulted in future surgery. Rectovaginal endometriosis is something I didn't understand until I was at least 8 years out of residency. I had never seen this picture published or presented in a meeting or in anything I had read. Subsequently, I did read some articles from 1917 that had this in it, but up at that point, I had not read the history of endometriosis and didn't understand that this had been published since at least 1917. For those of you who've done this type of surgery, you understand where I'm going, because you know that when the rectum is here and the cervix is there, that we're about to be in trouble. But in 1984, I didn't know that, so I incised here trying to get up underneath this and went straight into the muscularis. We had to open her to repair this and then come back later once we had her prepared for the bowel resection that required. This was a Adamian stage 4 retrocervical endometriosis with the predominant portion retrocervically. Remember, the septum's down here. This is not septum. It's in the rectovaginal space, but it's retrocervical, not rectovaginal down here. And that requires a lot of preparation and a good team. More recently, Griffiths et al. Reported that this type endometriosis was missed at the first laparoscopy in 14 of 16 cases. This was before the use of imaging to recognize this, so that the question comes up now is, will current imaging be able to demonstrate all or only some of these? Since we do not know that it can demonstrate some of them, then it's good to think about doing sonography before laparoscopy in patients with pain, particularly if they have posterior tenderness. Tubal endometriosis is another concern. Barnajat's group found at the laparoscopy that 11% of patients had tubal endometriosis, and when they had salpingectomies, another 23% were found microscopically only. So 34% of patients had endometriosis in that study. This is an oncology study. A lot of those patients were having bilateral salpingectomy for cancer prevention, but they also asked the question, in addition to cancer prevention, will it also benefit patients who have chronic pain? In adolescents, we have the opposite problem, and that is of size. I was able to take this picture and see the 400 micron and the 200 micron lesions at the time of laparoscopy, and we sampled those and showed those histologically. But on reviewing the 35 millimeter films and blowing those up, we could see lesions as small as 80 microns. Given that we did not see those at surgery, we didn't ask pathology to look for those. We can only guess since they have the same appearance that they are also endometriosis. That's something that those of you who have camera systems that are capable of this resolution can follow up on to see if those lesions have glands, stroma, positive CD10s, or any other markers. One of the things I learned in 1984 from Pete Hollis, remember Pete Hollis would be chairman of the ACOG in 1990. He sent me patients. He sent a patient in 1984 who had a left uterosacral nodule that I excised, proved it histologically. Good operation until he got back to her and he was still able to palpate the nodule because I had not done what he'd always done, and that is if he knew a nodule was there before he excised it, he, during the excision, used that to push the lesion into the field, and after he'd excised it, he palpated it again to make sure that he had seen everything because some of these cannot be visualized. After I started doing that, my patients were much happier. So if you have a nodule, make sure after you've finished excising it, that it really is gone, and keep going until it's really gone on exam. A probe can be better for some surgeries. That technique was one of the reasons that he, Harry Rich, and Gordon Davis were acknowledged in my first paper on laparoscopic and vaginal colpotomies, and they were instrumental in the development of all those techniques, including the 1989 Blue Sky definition of 5 millimeters that was used by Corneli and Koenigs in their definition of 5 millimeters as deep. I'm not going to discuss the specifics of imaging apps, biomarkers, myoelectrical activities, and others, only to note that these are working in tertiary care high-risk populations. We need research in primary OBGYN, pediatrics, emergency rooms, so that we know that these can be validated in all of those. This is another watch this space story. In conclusion, routine transvaginal sonography should be used or at least considered on any patient scheduled for laparoscopy for pain, particularly those with posterior retrocervical tenderness. So when you're doing palpation, examine both the retrocervix and the uterosacrals to prepare for surgery. Consider MRI if your radiology prefers that. If you're working in adolescents, look for 0.2 millimeters or smaller lesions. And if you have a palpable nodule, repeat palpation after you've removed it to be sure that it was removed. For markers, this is another watch this space story. They're promising in tertiary care. They need to be part of comparative research, and we need validation in primary OBGYN, pediatrics, gastroenterology, emergency rooms, and other areas, but those need to be done individually, not as a bulk. For those in clinical practice, you need to be prepared for any changes and evaluations that will be needed if these are found to be useful in low-risk patients. This is that link again for those of you who are interested in pursuing this concept. Thank you for listening. I hope this has been useful. Have a great day.
Hello, good morning to all of you. First of all, I would like to say thank you to all Nezet family, Cameron, Far, Sina, Adzi as a death, and a special mention to my friend No More Here Rustin. I feel so privileged to be a friend of them, and I always remember the little but special period of my life I have been in US to see their amazing surgery. They didn't know me so much, but I felt immediately part of the family. Thank you. Now I would like to introduce myself to all of you. I am Dr. Sosha. I work in Naples, Italy, and I am an obstetric gynecologist physician. I'm not sure to know exactly what is my role in this conference. I should speak about obstetrics problems in patients with endometriosis. This is not work, but in my opinion, what is important to say to patient is to let them know how can endometriosis change the physiology of their pregnancy and its impact in life. Endometriosis is a disease that has a profound impact on the quality of the life of women due to the associated chronic pain, dysmenorrhea, dyspareunia, and infertility. However, even getting long-awaited pregnancy, often after assisted reproductive technologies, patients with endometriosis have a high risk of obstetrics complications, such as miscarriage, this often, preterm birth, often around or before 28 weeks, preeclampsia, placental abnormalities like placental abruption, placenta previa, premature rupture of membranes, retained placenta, hemorrhage in labor, postpartum hemorrhage. Women with endometriosis who conceived by IVF may have higher risk of postpartum hemorrhage and preterm birth than those conceived naturally. Birth of small for gestational age infants with congenital malformations, stillbirth, and higher cesarean section rate. In addition, during pregnancy, acute complications of endometriosis may occur, such as spontaneous hemoperitoneum, which is rare, really rare, but it requires surgical intervention. The mechanisms of all the observed complications in pregnant women with endometriosis are not fully understood. All our hopes are in research, but what I often see is that is very, very important. It's percentage of miscarriage. So what is the take-home message? I know this is a little film, but the take-home message is very important for me, is that pregnant women with endometriosis require increased antenatal surveillance, and that in infertility life, early diagnosis is very, very important. So to prevent and treat this pathology. Also cause, if treated, all the things I said will be less in percentage. There are many, many papers. So if you have to have surgery, have surgery, so to have a better pregnancy. Bye from Italy, and thank you for the invitation.
Cuando sientas desmayar y que ya no hay fuerzas para continuar, has pensado abandonar.
No te olvides, tener cólicos no es normal, tienes que buscar ayuda. Si tienes cólicos incapacitantes, busca a tu médico, por favor.
Es hacer, pero tu corazón no.
Hola, aquí Gedeón Richter dejando un mensaje caminando por la visibilización de la enfermedad. Ninguna mujer debe padecer con dolor, ninguna mujer tiene que tener sangrados uterinos abundantes y tomarlo como normal. Algo te puede estar pasando. Atiéndete con tu médico, puede ser endometriosis.
Cuando parezca como si no puedes pelear más y se ve como si el camino llegó a su final. Cuando nadie en ti crea, cuando te cierren las puertas, por favor no te detengas, porque debes continuar. La esperanza te hará mirar más allá y la fe te da la fuerza de creer que vencerás. Ahora es tiempo de avanzar y del pasado olvidar y celebrar lo que...
We bring greetings from our center in India, Vardhaman Hospital. Today we shall be presenting a case of bladder endometriosis. Bladder endometriosis was diagnosed in this unmarried 32-year-old female complaining of severe dysmenorrhea, dysuria, and cyclical and non-cyclical pelvic pain. There was also a history of increased frequency of micturition, urgency, and other episodes of urinary infection. She had heavy bleeding and passage of clots. She was earlier operated in 2011 for extensive DIE endometriosis. On ultrasound, she had adenomyosis, adenomyoma, bilateral adherent ovaries, and a bladder nodule diagnosed on ultrasound. Here we see very severe adhesions of the bladder to the bowels. So we start the unraveling of the frozen pelvis from the left side of the pelvis, pelvic brim, the sigmoid and the rectosigmoid adhesiolysis is being carried out. We see the bowel loops densely adherent to the back surface of the uterus. We are using a manipulator. The bladder, as we see here, is almost directly adherent to the bowel loops. So to avoid mechanical and thermal injury, we are taking all precautions using a strong uterine manipulator. The uterus is anteverted and the bowel loops are being lysed, and the pelvis and the side walls are being cleared. We see that the left side fallopian tube has started making appearance, and we keep moving in the plane of dissection, and here we see the femoral end of the fallopian tube has been brought out. The similar is being done on the right side, and we see a lot of adhesions of the omentum and the bowel over to the rectosigmoid. Energy source used is harmonic. We are giving diluted vasopressin over the uterus. As we see, the bladder is almost totally adherent over the uterus. So we continue to proceed with the surgery in the pouch of Douglas and the medial and the pararectal spaces. To avoid bladder injury, we have already used ICG placed in the ureters by the help of a ureteric catheter. Adhesiolysis between the other bowel loops and rectosigmoid is being carried out. To go over to the bladder endometriosis, it is imperative to clear the entire pelvis first, and here clearing over the sectal promontory, we lift the fold of peritoneum up to open up the medial and the lateral pararectal spaces. As we said, ICG was already injected, so the ureter is showing in the green fluorescence, and that is a big step in such extensively adherent frozen pelvis to tag the ureters with ICG. The camera systems are enabled to pick up on the onlay mode. So we take extreme care. As we see here, the ureter is very densely adherent, and preoperatively, after giving the ICG, we have also inserted the number 5 bilateral DJ stents. So we see here that in the POD also it is totally obliterated, and the fallopian tube and adnexa is being lysed out. A small endometrioma in the left ovary is enucleated, and now we see here that over the isthmus of the uterus, the bladder is totally adherent. We work from the paravesical space, and we have applied the Rumi cup also, so that the DIE nodule is being separated from the isthmus of the uterus. Here we see such a big nodule, and this is the Rumi cup over which the bladder is being separated out. So the Rumi or the manipulator cup helps in a big way to localize the entire nodule and avoid injury and give us a handy plane of cleavage. Now here As we are doing the adhesiolysis, the bladder may open at any time, and it's important we just grasp the uterocycle fold of peritoneum and lifting up the bladder so that we can further reach. We see here there's a small rent made in the bladder already. This is the big nodule over there. So we start working in the paravesical space to gain clear grabbing the nodule completely, and here we see this is a cotton candy paravesical space, and working in this further, the nodule is totally marginalized and it is grabbed by the graspers. So it's very important to prevent recurrences. We do a complete surgical excision, as this girl had an extensive recurrence of the disease almost 14 years after the first surgery. So we need to be very careful, and we are getting very good planes of cleavage as we see. So now this is the last part of the nodule, which is adherent over the uterine isthmus, and a very good margin and complete clearance of the nodule achieved. And now we go ahead with the excision, and it is very important to do a partial cystectomy in this case and to achieve clear margins of the bladder as we finish the surgery. So we keep looking inside the mucosal layer to identify all endometriotic fibrotic nodule and carry on the excision. So here the bilateral digestants are visible, which were placed even before the surgery, and it is always a good dictum to apply the stents as if the nodule may be appearing to be away from the ureteric orifices, but during excision, at times to achieve completeness of the excision, we may go closer to the ureteric orifices. So a bilateral digestanting done prior is very useful. The stents are removed 4 to 6 weeks after the surgery. The nodule is continuously grabbed. Separate from the ipsilateral left-sided ports. So the big nodule is removed, and we further see here, and the mucosa has further bluish reddish nodule. So we make further excisional moves so as the whole of the nodule is removed. So these cases will be put on a longer bladder drainage after the closure, and usually in bladder endometriosis we have seen that even though the excision of the bladder is extensive, but the patients do not complain of the small bladder syndromes, and they get a good recovery even after a lot of bladder mucosa and the muscularis and the nodules are removed. So all the nodules are parked carefully and they are removed after the complete excision and the closure. So here we see that the stents and the are in situ, which will remain further for 4 to 6 weeks. So it's very desirable here to be careful in removing each and every bit, whatever is visible of the fibrosis and the nodular part of endometriosis. So these cases usually they do well in the post-operative phase. So all nodules removed. Do a tensionless suturing over the bladder. We open up the space of radius between the two medial umbilical ligaments, and the same is carried out with the harmonic ACE, the bladder mobilized. So this reduces the tension on the suture line. Now we are using V-lock barb sutures to close the bladder, and this is done through and through the mucosa in 1 or 2 layers. So usually we perform the first layer of closure and taking care not to involve the intramural or going close to the urethral orifice. The first layer is completed and the endeavor is to have a watertight closure. So once we reach towards the closure of the first layer, we inject saline in the bladder, and if there is any leakage from any site, we do extra suturing for that bladder rent. So here we see that there was a opening in the other portion of the bladder away from the suture line. So we take a separate vical suture with 3O vical, and it's imperative to do a watertight closure, though it should not be on extreme tension. But a multiple layer closure in such extensive excision is always a good precaution to take for any future bladder complications. So here we completed the bladder closure. All the nodular portions of the excised nodules are being removed, and it totaled almost to 8 centimeters. And this is the final picture, and we did, the patient remained in the hospital for 48 hours and the bladder was drained for 14 days. This girl, because of very severe pain, was on antidepressants. So in the post-surgical phase, we started weaning off her antidepressants, and now she is totally off her antidepressants and she is doing well. So this was the case of bladder endometriosis, the management and the post-operative follow-up. Thank you.
Hello everybody, I am Dr. Kamran Nejat, the founder of the worldwide EndoMarch. I would like to welcome all of you for another session of the worldwide EndoMarch, and I would like to thank all of the participants, all of the audience around the world for their interest in this series. My thank on behalf of myself and co-founders of the Worldwide EndoMarch, Dr. Far Nejat, Dr. Sina Nejat, Dr. Azadeh Nejat, and Barbara Page. And also, we would like to thank all the chapters of the Worldwide EndoMarch around the world in more than 60 countries for their significant contribution and assistance in helping patients with endometriosis and their families, and in helping to raise the awareness about endometriosis and its implications for women and their families and the society. Also, we would like to thank enormously the participants of every session, and in this session we have two prominent speakers, Drs. George Christopoulos and Dr. Sonita, that they are both very experienced from Europe and from India to address the very important issue of the adenomyosis and also myoma of the uterus and its relation with endometriosis and its implication with endometriosis and in patients with endometriosis. All of these efforts are for patients and their families, and we are lucky to have this time another one of our patients that another one of our patients, Miss Brittany Bushera, that she is going to share her story and her journey with endometriosis and adenomyosis and pain or issues related to her, as the story of the last month with Miss Lily Cooper was very, very popular. And because of that interest, that more than 8,000 people watched, we have included and we are going to include more stories specifically each time about the patient's stories. And also the efforts of Worldwide EndoMarch is continuous. There are a large group of volunteers that around the globe work and try to do the mission of the Worldwide EndoMarch. And in the headquarters, these are under the direction, guidance, and efforts of Zoe Pennington, Tiffany Letosky, Eliza Ackroyd, and Andrew and Lily Cooper, that are all volunteers and continuously doing a lot of work. There are many other people that they are doing in these efforts, and I'm sorry if sometimes I forget to mention everybody. But a great and significant thank goes to all of you and all the volunteers, because the basis of these educations are volunteers. The goals are that we make sure everybody knows about endometriosis, about adenomyosis. The word of diabetes and hypertension is very easily understood everywhere, but endometriosis is not easily still recognized all around the world as easily as hypertension or diabetes. But we are making progress. We are making it easier for people, for physicians to diagnose and treat endometriosis, and hopefully someday we will find a method of prevention. As you know, Worldwide EndoMarch has developed an app that it has dedicated to the society. It is completely for free, and it costs many years and significant amount of budget to produce it. It is called Nejad Endometriosis Advisor, and easily it can be used for the diagnosis of endometriosis with high accuracy as a guideline to help the patients around the world. Areas that there is no operative laparoscopy or there are no tests, other ways to diagnose endometriosis. Now, saying all of that, I would start, and I would like to start in this session here, our session of the endometriosis and adenomyosis and fibroid with Brittany Bushera. And Brittany, start please and go ahead and tell us the story of your journey with endometriosis.
Absolutely. I just want to say good morning, good afternoon, good evening to anybody that is watching. So I will just go ahead and start my endo story. So endometriosis was not spoken about before my diagnosis. I had no idea what it was. I heard about it being bad periods, but I had no concept about it. Now that I've done more research, I know that it's often underreported because symptoms are things as women like to brush off every day. For example, having a painful and heavy period, a frequent UTI, lower back pain, IBS, and SIBO. In the early stages of my symptoms, a lot of the times during my meetings with doctors, they would say that the pain I was feeling was normal, or just to take a pain reliever to deal with it. However, since my symptoms were interfering with me going to school, being able to sustain friendships, and not being able to go to work, I knew that was not normal. I remember being at a friend's house and having this excruciating pain on my left ovary. And the way I like to describe it was like a electric sewing needle that was on and on overdrive on my left side ovary. And I remember not being able to breathe and feeling extremely lightheaded and nauseous. The pain subsided the next day, but it happened again the next month around my next period. It was about a whole year of that same cyclical pain before I decided to go see my gynecologist about it. She told me, based on where my pain was, she didn't think it had anything to do with my period. She thought it was something to do with my digestive system and referred me over to a gastrologist and a nutritionist. And I said, okay. However, the pain started to get worse, so I decided to get another opinion. I met with another gynecologist and she started asking me really pointed questions like, is sex really painful for you? Are you having bad pain days? So bad that they keep you from working? And I was like, of course, yeah. So she prescribed me a new birth control, but the pain started to get worse. I saw more doctors, was put on numerous medications, but nothing seemed to help. It was to the point that when I worked out, it would leave me out of breath, was having constant nausea, extreme lower back pain. It felt like this buildup of different symptoms, and I felt awful and not like myself. I started to get at a point where I felt like I was going to feel this way forever, and I knew I didn't really want that for myself. I felt so defeated and frustrated. It was many years after that I took my own health into my hands and found a doctor that would help me. I was lucky enough to find Jacqueline Della Merced. She actually gave me the best advice and referred me over to Dr. Najat to get my laparoscopic surgery done. Endometriosis is a disease where the tissue, similar to the lining of the uterus, grows outside the uterus, and it starts to attach to all kinds of tissue. For me, endometriosis attached to my ovaries, bowel, bladder, and back. I'm really grateful for Dr. Najat because he actually told me I'm not going crazy. And as an endometriosis patient, you tend to feel like you're going crazy because you don't get enough answers. And you're just left going, what is going on? And giving me my life back. My advice to those that are dealing with endometriosis is to really trust your gut and not be afraid to get those second, third, 20th opinions. I think it's really important that we start talking about these pains women are feeling in a different way. I think it's important to speak up and elevate the conversation. And that's why I'm so grateful to be here today, so I can hopefully help you get some more clarity. But yeah, that's my story.
Thank you very much, Brittany. You are very, very kind. Thank you for your comments. And that brings us to the issue of association of endometriosis and adenomyosis. And what we are going to address is with Professor Christopoulos from Greece. He has extensive experience about managing patients with adenomyosis. And there are so many questions, and the question that we have also posted it, we have combined all these questions that Dr. Christopoulos is going to address it one by one, and also the association of adenomyosis with endometriosis. George, please go ahead. Thank you for being in the program.
Well, thank you very much for your invitation, and hi to everyone. I think you're doing a great job. I think it's so important to address these issues and educate the women around the world about these very important problems. Well, I would like to make a very brief introduction to explain what adenomyosis is. And adenomyosis is basically the presence of endometrial glands inside the myometrium, and that's where the word derives, adenomyosis, gland and muscle. Now, how this happens, it's not totally understood. We think these are potentially metaplastic problems or genetic problems or immune problems or the combination of these problems. But the end result is that when these glands find their way inside the myometrium, they cause fibrosis. And fibrosis means thickening and hardening of the muscle. The end result of this is extensive and very powerful contractions, which we call hyperperistalsis or dysperistalsis, which means abnormal contractions, and that is what's primarily causing the pain. So talking about symptoms of adenomyosis, which is the question, I think the main symptom is pain. And pain could be in various forms. Could be cyclic, which means painful periods, which in medicine we call dysmenorrhea. It could be painful intercourse, which in medicine we'll call dyspareunia. It could be chronic pain, i.e. pain continuously, women suffering outside the menstrual cycle. It could end up with bloating, which is swelling of the abdomen, and of course, infertility. So this is a combination of symptoms that adenomyosis causes. And of course, there are different types of adenomyosis, and this we will address later on. But I would say the primary symptom, like with endometriosis, is pain again. I don't know if this answers the question.
Yes, excellent. Thank you very much, George. Now, there is one question that Dr. Sina Nejat would address. What is the relationship between adenomyosis and infertility, and how do we deal with it?
As mentioned, first of all, good morning, good afternoon, good evening to everybody, and thank you for the opportunity. As you heard, adenomyosis is like endometriosis, is a general definition. We have variety of the adenomyosis. Actually, Dr. Christophertis has his own great classification. So it depends how much of the uterus is involved with adenomyosis. Is it glandular? Is it diffuse? Is it fresh or sclerotic? So in general, depends on the type of the adenomyosis. It definitely could affect the fertility. Mostly implantation could be affected. It could have heavy bleeding, poor responders, because majority of patients who have adenomyosis, they have endometriosis too, and it becomes a multifactorial who affects the fertility on different aspects.
Thank you very much, Dr. Sina Nejat. The next question is for Dr. Sunita. And Dr. Sunita, there are a lot of, again, questions in relationship to adenomyosis, myoma of the uterus, fibroids. And please go ahead, describe what are fibroids and what are the symptoms and how would you manage them. It is okay if you address all of them at the same question. Dr. Sunita has extensive experience in respect to infertility and myoma of the uterus, pelvic pain, endometriosis, and she has been involved significantly in teaching and managing patients. Please go ahead. It is a pleasure to have you. Please unmute your camera.
Thank you, everybody. Sienna, it's a great pleasure to join you in this journey of EndoMarch. Thank you for giving me this privilege to be with you all and to answer and address the society at large with various concepts and misconceptions and understanding of the subject more better. So fibroids, these are the tumors of the uterus. How we can have adenomyoma. Similarly, there can be a tumor in the uterus. Now, these fibroids we call, or a myoma, another synonyms, they can be within the uterus They can be in the wall of the uterus or they may be outside the uterus. And depending upon their size and depending upon their location, they can vary in their symptoms. Those myomas which are in the cavity of the uterus, these myomas obviously will cause you pain during menses, excessive bleeding during menses, or maybe it will cause fertility issues. Those within the wall of the uterus, and if they are big enough, they may cause a pain, chronic pelvic pain, or only pain during menses, or it may be during the relationship. While the myomas, which are outside the uterus, we all know that in front of the uterus is the bladder, urinary bladder, and behind the uterus is the colon. So if the myoma is anteriorly compressing, it's a big one on the anterior aspect of the uterus, then it will cause a bladder symptoms. If it is on the back side, it will cause pressure symptoms on the colon as simple as constipation or maybe pain while passing motions. If they are on a lateral side of the uterus, sometimes they can cause obstructions to the ureters. That may give acute pain to the patient and she may need a emergency attention. So depending upon their sizes, depending upon their locations, depending upon their number, sometimes they may be inside, they may be outside. And most importantly, everyone should know that sometimes it may cause just the lump. A lady may come saying, I'm feeling something in my lower abdomen. It's bulging. My pant is no more now fitting me. And sometimes you just find it when you go for a health checkup. So they are totally asymptomatic and you are accidentally finding them in your health checkup sonography reports. So various things they can.
Thank you very much. The next question is for Professor Christopoulos. The endometriosis and adenomyosis, how often in a patient has both of them? And are there different stages for adenomyosis? What are mainly, how do you make the diagnosis of adenomyosis in a patient?
Well, thank you, Cameron. I just want to say that whilst endometriosis is a well-studied disease, it's been studied extensively for many years, and there have been tens of thousands of publications, adenomyosis is a relatively younger disease. There are fewer years that people have been studying and publishing on adenomyosis, and the main reason for this is imaging techniques. So it's progress in technology that has put adenomyosis on the map. Until the 80s, the adenomyosis diagnosis was on histology reports from hysterectomy. But after 1980, with MRI, magnetic resonance, and with the ultrasound, and with the possibility of many doctors having ultrasound in their offices, that people have started recognizing this entity. So that's why I use the word young disease. So it's a younger condition. Now, endometriosis, we know, it's a common problem. It happens to many women, and not only in women with pain, but also in women without pain. Adenomyosis is also happening in a reasonably proportion of women, and it's very commonly found, especially in women with pain, with endometriosis. The publications vary. In my series, we have about 40% of women with adenomyosis also having endometriosis. But you have to understand that this is an important ethnic difference between ethnic groups. There are variations. In some series, endometriosis and adenomyosis, especially in patients who suffer with pain, can be found in up to 70 or even 80% of women. So endometriosis and adenomyosis seem to share some common pathogenic mechanisms, like genetic mechanisms or immune problems that both end up having these two conditions at the same time in the same patient. And that's why pain, and one contributes to the other.
Very good. Well, thank you very much. We have to recognize, dear audience, that since the introduction of video laparoscopy and the revolution of modern day surgery, the technology has advanced significantly. We have excellent cameras now, excellent light sources, and high definition monitors, 3D visions. Thus, we are able to see in the abdominal and in the chest cavity, in all the body cavities, much better. We can see the anatomy and the pathology much better than we were able to see before. Thus, we are able to diagnose endometriosis that a lot of times are small little spots, and ultrasound doesn't show it, MRI doesn't show it, CT doesn't show it, but when you look, you can diagnose. For example, all the literature, all the medical publications, they were mentioning that only about 20% of patients who have fibroid have endometriosis. Until recently, we have published 2 papers and we have done significant research in this area, and we are finding more than 85% of patients who have fibroids have endometriosis, pathologically proven. So we have proved that women who have fibroids, more than 85% of them have endometriosis. That has a big implication. That means if 1 out of 5 women in the world has fibroid, more than 85% of them have endometriosis. The number of patients with endometriosis in the world is far more than 200 million. That we have been saying, and we have said that the number of the patients with endometriosis is far more than 200 million. And time would prove that that is correct. So women, patients are not imagining it. It is not in the head that there is pain. So sometimes the adenomyosis or myoma by itself might not cause pain, but that endometriosis component might cause pain, or it might contribute to infertility. Fibroid by itself might not contribute to infertility, but that endometriosis associated with it does. And also this has another implication, as patients with endometriosis could have a higher chance of cancer. And that brings me to the question that asked Dr. Farnejad, what are the risks of the patient who have adenomyosis, endometriosis, and fibroids and dealing with cancer? Dr. Farnejad? Okay, we will proceed with, it seems like Dr. Farnejad is not there.
No, Dr. Far is here. He was muted. He's back. He's unmuted.
First of all, thank you very much for the invitation, and good morning, good afternoon, and good evening, people around the world. So this question has 3 components: the possibility of the malignant transformation of endometriosis, possibility of malignant transformation of adenomyosis, and also malignant transformation of myoma. So definitely we know that endometriosis could become malignant. The most common area of the endometriosis become malignant is on the ovaries, and there are histologically different types of the cancer could arise from the endometriosis on the ovaries. Also, endometriosis of other parts of the body, like a bowel, and sometimes bladder, and even other parts of the abdomen, like incision of endometriosis, all could become malignant, unfortunately. The chance of adenomyosis become malignant also exists, but the chance is less. No, we don't know the possibility. We know that the uterus could have cancer of the lining of the uterus, or endometrial cancer, and sometimes adenomyosis that has become malignant, but the chance is much less. Chance of the uterine myoma become malignant also exists, but it is less than maybe 1%, based on different reports, which is called sarcoma. So each of them, unfortunately, there is a potential to become malignant, but overall, the good news is the chance is low. It's not zero, it exists based on the areas of the disease. The chance is different, but awareness of this condition is more important than a statistic. But unfortunately, it could happen to younger patients, and most of them are perimenopausal and sometimes after menopause.
Thank you very much, Professor Farnejad. The next question is for Professor Sonita. Is in relationship to fibroids, when do you do surgery if the patient wants to get pregnant? When do you do surgery if the patient, and what kind of surgery do you do if the patient doesn't want to get pregnant? And or when are you going to do IVF for this patient? You are muted. You are muted, Professor Sonita.
Thank you for your question. It's really $1 million question in infertility, when to operate on a myoma and when not to operate on a myoma. Because if you operate on a myoma and if patient doesn't conceive, then you are answerable to it. So when you are in doubt, cut it out may not be right in a fertility. What is important, if the fibroids are inside the cavity, we call it as a submucous myomas, and they are large enough or they are multiple, and you don't have any other reason why patient is not fertile, it is advisable to remove all those myomas which are within the cavity. Now the question is, if the myoma is outside the uterus, that is subserous myomas, these are myomas which are not needed to be removed because they are not directly coming into the contact for the implantation per se. Very, very rarely, if they are at the corneal region and if they are blocking the fallopian tubes, then maybe the reason you need to remove them. So unless the subserous myomas, those myomas which are outside, probably you don't need to remove for your fertility. The main important, always a controversial point is the fibroid which are within the wall of the uterus and they are medium size, like 4 to 5 centimeter. They always cause a dilemma for the fertility specialist. So any myomas which are those medium size, but they're compressing the cavity, they are going to alter the implantation. And those cavity distorting myomas, even if they are in the wall, not inside, they should be removed. Only those myomas which are very small myomas, they are away from the cavity, they are in the wall, they may not be removed. But if they are multiple, for example, there may be 2 centimeters, 7, 8 myomas, then altogether they may impact. So in but it's not advisable to do the surgery for such a small myomas which are located at multiple. So sometimes the fertility specialist might have to use medical line of treatment to temporarily reduce them. No medical line of treatment will permanently dissolve them. They are there just to reduce the size. So it is the fertility expert who can tell in that patient. But you had very rightly said that myoma may be associated with endometriosis. And if it is a subserous myoma, one don't know the cause why patient is not becoming fertile or pregnant, then putting a laparoscope inside to examine any other factor, you find associated endometriosis. But if I had gone inside doing laparoscopy, and if the patient has significant size of 6 to 8 centimeter, I would remove even that myoma, because sooner or later she will need the surgery for that. So it's very important that you sit with the patient, you have a proper mapping of the myomas, either by the great sonologist or by MRI. Sit with and discuss the patient, how you feel those myomas are affecting the fertility, and probably you will help her to restore her fertility, or probably her implantation after the IVF result will improve if we remove those myomas. I think technological advances, as you said, whether hysteroscopy or laparoscopy, making it a daycare surgery, has helped the physicians, surgeons, as well as the patients to undergo this successfully. So one more request is, whenever you do it, try to do laparoscopy.
Thank you very much. So there is a question, and that is also for you, Professor Sanita, in relationship to myoma. And this patient says, I have had many failed IVF cycles, and patient has fibroids. And her physician doesn't believe the fibroids are the contributing factor. So what should she do? She has had many failed IVFs. Could she keep going having IVFs? And her physician says fibroids do not cause infertility. What would you do? What is your recommendation?
I will do first her IVF. I'll freeze out her all embryos, and I will do removal of these fibroids unless I find the other reason. If the fibroid I feel are within the cavity or compressing the cavity, definitely I will suggest the fibroids are the cause why implantation failure is happening. I will remove it definitely.
Thank you. So, Professor Pistopoulos, exactly another patient, she has had many failed IVF cycles. She has diffuse adenomyosis. And what would you do, and what do you recommend that she should do?
Well, that's a very difficult question, because adenomyosis can be of different types. And this is our classification, which we have presented some time ago. Adenomyosis can be, like you very correctly mentioned, diffuse adenomyosis, which is affecting the whole of the uterus. Or it can be focal adenomyosis, which means more localized disease in a particular area of the uterus, which could be the anterior or the posterior aspect of the uterus. Now, we have divided the focal types of adenomyosis into three different categories, which is the larger lesions, which are very hard, and we call sclerotic, which means hard. Then some smaller lesions, which are nodular, and they're closer to the top of the uterus and near the ligaments, and we call those nodular adenomyosis. And then we have a very rare condition, which is cystic adenomyosis, and that is found in the younger age groups. Now, it's very important to understand these types of adenomyosis and surgery, because you have to understand that whilst you remove a fibroid, the uterus remains more or less unaffected. The uterus remains intact. But if you remove adenomyosis, you actually remove part of the uterine wall. because adenomyosis means fibrosis of the uterine wall. So the bigger the size of the lesion, the more uterus you remove, so you affect and you alter the future fertility and the capacity of this uterus to carry out a successful pregnancy. So one has to be very diligent in how to manage, how to decide which lesions are adequate, are presenting themselves for surgery, and which lesions should not be managed by surgery. Now, when it comes to diffused adenomyosis, which you mentioned, I think it's impossible to remove the whole of the adenomyosis. Some workers have attempted that, and they've given some interesting data, but it's very difficult surgery and can end up with actually destroying the uterus. So I think for diffused adenomyosis, it's better to do conservative treatments with GnRH analogs, trying to stop the menstruation for a while, and then attempt an IVF cycle again. For other types of adenomyosis, which are the focal lesions of adenomyosis, I think surgery can be efficient, especially if these lesions are less than 30% of the uterine mass, of the uterine wall, because in those particular cases, you can remove more or less the whole lesion until you reach healthy myometrium and then suture together good myometrium, which gives a very strong uterine scar with a successful pregnancy. And our experience with women who suffer from focal lesions is that the majority of these women can be managed by laparoscopy, like you mentioned earlier, and can be managed conservatively without having to go to a full hysterectomy. Now, when it comes to IVF attempts, again, if you have focal lesions and you have multiple failures, I think one can consider to do surgery for adenomyosis, but has to be extremely specialized and experienced in this type of surgery, because you have to be very careful how much uterus you remove and how much lesion you can successfully remove, and then replace, suture the uterus again to make it a functional uterus. When it comes to diffused adenomyosis, unfortunately, the only solution as far as I'm concerned is medical treatment and then carry on with future IVF attempts.
Thank you. When you remove these adenomyosis lesions, how long do you tell the patient to wait to try to carry a pregnancy, and do you ask all of them to have a cesarean section?
Well, thank you very much. It's very important when you remove adenomyosis to have an accurate diagnosis preoperatively, so that you know that this patient is eligible for good surgery. So you have to suture healthy myometrium, like I mentioned beforehand, with healthy myometrium. If you suture adenomyosis together with adenomyosis, you don't have a very strong scar, and that is a problem. So it's very important for the surgeon to be able to recognize the limits of the lesion and remove it as much as possible and find healthy tissue and suture that together. If you do that, then I think about 6 months is probably sufficient to allow this uterus to heal completely. And then, of course, we assess by sonography, make sure that the lesion has been removed. And after that, I think it's safe for the woman to go ahead with a pregnancy. Now, as far as outcome is concerned, I think I would opt for a cesarean section. Definitely, I would do a cesarean section, not a term, but probably a wee bit before term, around 37, 38 weeks.
Thank you.
George, can I ask you a question? George, thank you very much for excellent explanation. 2 questions. One, what do you think about the role of the myometrial ablation and also uterine artery embolization in women that want to get pregnant with diffuse adenomyosis?
Well, to be honest, I have not had much experience with uterine artery embolization, neither have I got experience with myometrial ablation. My experience has been mainly surgical to actually remove the problem. I have not managed many women requesting fertility with embolization, so I wouldn't know if that would be the correct treatment for women with diffused adenomyosis to offer them uterine artery embolization. I don't know what's your experience with this condition.
Well, you know, I am in New York, and because we are besides oncologists, I get this referral for these women that don't want to get pregnant, they don't want to have hysterectomy. They want to get pregnant, and like that patient that had failed several courses of IVF, and one subject has come up that maybe we should try uterine artery embolization or myometrial ablation. So me personally, like you, don't have enough experiences. But definitely I have seen patients that have been referred to me or they came to see me for consultation and this subject has come up. I don't know if Dr. Sanuta Tondo or Cameron or Sina have any experience.
No, I'm not have uterine artery embolization. Neither I feel it will effectively work for these infertile patients. I'll be little worried about doing uterine artery embolization. But what I do with this diffuser, I think George has answered so beautifully about the adenomyoma and the concern with the surgery in an infertile group. But in diffuse adenomyosis, what I do is I always go for the frozen embryo transfer. I freeze the embryos and around 6 cycles of GnRH agonist or amenorrhea, and then I do the frozen embryo transfer. And I see it gives me wonderful result. It's not only, we all know that it is not only the reduction in the size of adenomyosis, but it is decreased into the chemicals, the interleukins and other which natural killer cells and all those get decreased. You get a favorable immunity, and because of the shift towards the favorable immunity, we all know that adenomyosis, apart from the structural things, they also alter the implantation because of altered local immunity. And by making a amenorrhea for 6 to 7 months, we help them to shift to the favorable immunity and hence the implantation. I will never go for the fresh transfer. I will never do the suppression first and then stimulation and a fresh transfer. Because whenever I'm stimulating, I'm causing supraphysiological level of estradiol and I'm changing the immunity quite a lot. So I will always suggest freeze-on, give amenorrhea of 6 to 7 months. If it is a very massive adenomyosis, you may go for 9 months and then do the frozen embryo transfer. Only thing is, if you are not doing obstetrics, give it to the obstetrician who knows how to manage not only the ART pregnancy, but these adenomyotic uterus. Usually you will have oligohydramnios or a small size babies. So one need to be very clear about managing those patient even, because ultimately carry home baby rate is what is important for all of us.
Thank you, thank you very much. In general, there are no significant data to one way or the other, but there are anecdotal data that we should not use uterine fibroid embolization for the patients who want to have children. Mainly, it may cause intrauterine growth retardation because the blood supply to the uterus would be significantly less. Thus, I don't believe it is a good idea to do uterine fibroid embolization or uterine artery embolization in case of adenomyosis excuse me, when the patient wants to get pregnant. In case of myeliosis, again, there are no data, but we do not want to damage the uterus. If the adenomyosis is superficial, and I usually very carefully, selectively, I try to gently desiccate it as long as it is a focal area and it is not too much. Then the patient doesn't have to wait a long time. But if it is diffuse adenomyosis, hormonal suppressive therapy between 6 to 9 months and sometimes longer, that is what it is advisable. And that brings me to the next question that I would like to ask Dr. Azadeh-Nejad, that how many kind of fibroids there are and what is the association between them and endometriosis, if you would like to address it. And if the patient doesn't want to have hysterectomy and she has already completed her childbearing and she has all the children she wants, but she has symptomatic myomas and she still wants to keep her uterus, how would you manage her? This is a patient who has had children, she has fibroids, and she says she doesn't want to have hysterectomy, and she is 55 years of age.
Good morning, everyone. I think Dr. Sunita and you addressed the types of fibroids as far as where they are, where they're located in the uterus, how we divide them into the cavity that are called submucosal, into the muscle, intramural, and then outside of the uterus, they're called subserosal. As far as the endometriosis, what percent, but to answer those, I think you answered the 87% of the patients with fibroid, they do, there was a study in 2016 that we published that showed more than 87% of the patients with fibroids are histologically have endometriosis also. So those two, I think you answered them. As far as how do you manage a patient that does not want to have a hysterectomy, but has multiple fibroids and is symptomatic? You know, we've done myomectomies. You could bulk the fibroids by doing a laparoscopic or LAM, remove the fibroids to reduce the bleeding and the pressure on the pelvic organ. Also, you can manage them by putting an IUD if they have bleeding, but if it's a 55-year-old still wants to keep her uterus, there are times that we do myomectomy.
Thank you very much, Dr. Azadeh-Nejad. Dr. Sina-Nejad, there is a question that some patients are worried about fibroid and cancer, and what percentage of the patients with fibroid have cancer, and how should they be managed if you remove them by laparoscope or by laparotomy? How would you manage it? And then also Dr. Farnejad, from an oncology point of view, after you answer it as a non-oncologist, and then Dr. Farnejad would address it as an oncologist.
Well, this is a good question. But before I answer this question, I go back, briefly address what Dr. Farr and Sunita and George mentioned about embolization and myeliosis. I've done surgery on patients who have had embolization and myeliosis, both after they have failed getting pregnant or their symptoms continue. I do agree with all of you. It is not a good idea to embolize adenomyosis specifically for two reasons. One, we don't know what we are embolizing. Second, it makes, if you have to do surgery, it makes it more difficult. When it comes to the fibroids, there are some data from the radiology standpoint to address that they could get pregnant. The one that I get is the one who didn't get pregnant. And when I want to do myomectomy on them, the necrotic or sclerotic fibroid makes the surgery more difficult. But in support of what all the panel said, in infertility patients specifically, it is better to approach it surgically. Now, to answer this question for you, statistics of a cancer and myoma. We don't know if the fibroid is getting cancerous or no. This is a sarcoma who develops by itself on the patients that mimics the function of the, or similarity of the fibroid. And Dr. Farnejad could answer it better than me. Regardless, at the time of the surgery, we have to think it could be cancer, even if the statistics are low and the chances is less than 4 in 1,000. Still, we take the precaution by proper tissue extraction. So it's been mentioned properly. There are 3 parts in myomectomy. First, removing the myoma from the uterus. 2, reconstructing the uterus. And 3, extracting the myoma from the abdomen. And this all has to be individualized.
Thank you very much. Dr. Farnejad, would you like to address that?
Well, the issue is that this sarcoma or malignant myoma starts de novo, it starts it from the beginning, or myomas become malignant. It is a good subject, but definitely we know some benign fibroids that has been there for a while and did not cause any problem, later on become malignant. And the way that we know is that this patient has had fibroids and has been watched for years, and all of a sudden some changes happen either in the size or characteristic of the fibroid, or the cancer, patient comes with metastatic cancers. So we know that this happened, unfortunately, and because this is a very aggressive cancer, if the patient had it years before, she would have had sign of metastasis. And this could happen most of the time that the patient has fibroid before it goes to menopause, and then after the menopause, all of a sudden, these fibroids that are supposed to be fibroid now get bigger. And either put pressure in the abdomen or the surroundings area, or causes other issues like bleeding, and comes to the physician. But there is a potential that some of this cancer starts de novo, and even though it's small, become malignant. Especially we see it inside of the uterus, that sometimes the patient has a small fibroid, and when it is removed, it is cancer. The possibility is low, but we see it.
Thank you very much. Would you like any of the panel, George, Dr. Sunita, anybody has any additional point that you would like to mention? Would you like to say anything else? Do you have anything to add? Perfect. Brittany, I'm sorry.
One more thing I'd like to address. When we talk about fibroid, again, there are variety of the fibroid, and that's, we have to communicate with our pathologists. Like I have had patients who myoma, they have done myomectomy, pathology has come back atypical myoma. Myoma, I've had, they call it bizarre myoma. And then the variety of the myoma. So working with a knowledgeable pathologist to look at the tissue globally is also very important. Thank you.
Thank you very much. I would like to thank all the panel, Professor Pistopoulos, Professor Sonita, and Professor Farnijad, Professor Sinanijad, Professor Azadeh for their contribution. Also, I would like to thank Dr. Agrawal and Dr. Jackman for their contribution to this panel. And I would like to thank immensely the organizers from the headquarters of the Worldwide EndoMarch, Zoe Pennington, Eliza Ackroyd, Tiffany Letoski, and Lily Cooper, and Anuj Wade. They worked for the whole month to put a program together for you, and we thank you. We thank them very, very much, because Worldwide EndoMarch around the world is done by volunteers. I would like to thank Brittany Bushera for her contribution for this session. The session of next month would be about diet, about acupuncture, about physical therapy, about herbal treatment, about fitnesses, and other alternative treatments for treatment of endometriosis, for adenomyosis, etc. We thank all of you around the world for your interest and contribution and helping patients with endometriosis and adenomyosis. And we wish you wonderful health. We continue to remind you to be careful, stay healthy, socially distant, and take care of your health. We wish all of you the best of luck, and we thank you very much again for your participation and your interest. Best of luck. Bye-bye.
Thank you.
We are very privileged to have our guest today, the physician guest of that, who is a visionary, and she is a gifted reproductive endocrinology and infertility specialist in Los Angeles, who is internationally known, and patients from all over the world travel to see her to gain their wish to get pregnant. Brilliant Dr. Kelly Beck, who has had significant training in endometriosis, infertility. She has been trained at Hopkins, the best institutions in this country, Sinai and Cornell. And she presently practices in Los Angeles. Also, two couples of her patients, Roya and her husband Scott, and their daughter Anaya, and also Carly and her husband Zach and their son Jacques. They are also joining our webinar today. We thank you for listening. Past webinars, you can watch them in endomarch.org, and there are many, many sessions that you can watch. You can ask your questions. We have our fellows, Dr. Shruti Agrawal and Dr. Deborah Lee, and also Dr. Makam Tavallaei. They are all also joining us to answer your questions. And we will start, as I said, the endometriosis is a social issue. In developed countries, the birth rate is in some cases less than 0. And in our country, in US, we are going towards that direction. So endometriosis is one of the major issues, and hopefully with your interest that you are raising awareness, we will have better and better results. Saying so, I would like to introduce first Dr. Kelly Beck, that I mentioned to you. She is going to express to you her interest and how she sees patients with endometriosis. As I mentioned to you again, she is completely gifted. Practically, we work together on a weekly basis, and we have had numerous patients. I cannot believe how she diagnoses endometriosis, but she is incredible. Dr. Beck, please go ahead.
Dr. Najat, thank you so much for having me on your on this forum, and I really I'm so grateful to Roya, Scott, Zach, Carly, and your children for joining us. This is like so kind of you. But I do think that endometriosis is something that does affect a lot of women, and unfortunately is either undiagnosed or misdiagnosed for years. And so I know that we're probably going to go into when and how do we diagnose it, because it's not always that you need a biopsy, and there are times where you can detect it on physical exam. And because the true way to assess endo, if you have a suspicion for it, is laparoscopy, and it is surgery, and it's invasive. It's one of those things that we really have to kind of come to an understanding and educate women about, like, when should you seek it? So when you have irregular menstrual cycles, or you have pain, or you have things with GI symptoms that you're being diagnosed as having GI issues, sometimes it could be endo on your colon, and that's what most women are diagnosed as having IBS or irritable bowel, or having something called SIBO, which is a small intestinal bacterial overgrowth. And so I do think that just being able to identify it for women and asking for answers, because a lot of times when women have irregular menstrual cycles, or they have burst ovarian cysts when they're younger, one of the first knee-jerk reactions that they get when they try to seek help is that they're placed on birth control pills. And I think before getting placed on birth control pills, it is good to first try to get some type of answers. And I think I'm really glad for opportunities like this to help educate people. So thank you.
But Dr. Beck, how do you feel about, in general, the patient with endometriosis? Is there anything, comments that you would like to give? The difference or the age difference of as the patient getting older, do you have any specific recommendations for younger patients, female and also male, about freezing their eggs and sperm? How do you feel about that? Roya brought that up.
This is something where oftentimes when I suspect endo in younger women, because I have a lot of women who come in their 20s and 30s for egg freezing. When I have a younger woman and they have a lower number of eggs for their age, you typically see about 10 to 20 follicles on each side, or they have a very low AMH. So their AMH should be like 5 to 8, and it's less than 1. And they have really no other significant red flags. They don't have a history of smoking or vaping, or have an autoimmune issue, or had pelvic surgery or infections. One of the first things I try to rule out is endometriosis, and I look for any potential physical findings, whether their uterus is deviated to the right or the left, if there's thickening of their uterosacral ligaments. But when you have a young woman who comes in just for a fertility assessment and they have a lower number, I think that, and there's no other red flags, I always rule out endometriosis. So that's like one category of patients. And usually, they're asymptomatic. They came in for something elective. They're usually angry when I bring it up because they just want me to freeze their eggs, but they don't understand that, like, if you have endo and I freeze your eggs, it's not going to work. The eggs are not going to thaw well. You're going to go through the motions. It's not my recommendation. And can you find a doctor who'll freeze your eggs? Of course, you can go anywhere and they'll freeze your eggs. But you have to make sure, is it medically appropriate for you, and really make sure that you have the information so you can really make the appropriate choices for your fertility. That's one. The second is if you have a known uterine defect, like a congenital septum, or there's something abnormal about the uterus, 50% of those women have endometriosis. So I know right away it's something that I'm going to be looking for. If they have a hysterosalpingogram, which is one of the basic fertility evaluations where the radiologist assesses the uterus and the fallopian tubes, and it's really deviated to the right or the left, there's something going on. If they haven't had pelvic surgery to explain that type of deviation to the right or the left, you have to rule out endometriosis. But I have to say, in a case when you have a woman who is closer to 40 or over 40, who has done multiple IVF cycles, they haven't gotten normal embryos, then is it the first thing you're thinking about? No, you're trying to get them a normal embryo because you think, well, 10% of eggs are going to be genetically normal and you don't want them to lose that window. So would I tell them to do endosurgery first? Probably not, because I'd want to not have them lose that window for opportunity. And every time you do IVF, it can make endo worse. So you don't want to address the endo until you're done harvesting embryos. So I just want you to know like how I kind of look at different types of patients. But when I have a patient and we have normal embryos, one of the first things I would recommend is if they've never had children before, making sure we've checked the uterus, that there isn't something on a microscopic level, even if they're completely asymptomatic, because I want to make sure that I've given that embryo every opportunity to be successful. And so in someone who's never had children, once I get normal embryos, I do the endometrial function test. I know there's other tests out there that are commercially available that are backed by Wall Street, but they're not really appropriate for someone who's never had children.
Thank you very much. This is very insightful and very informative, as you know, and all research has shown that patients of yours or a combination, some other REIs that we work with, and the majority of the couples, more than 90% of them that are trying to have children, all of their tests are normal. The husband test is normal, and they do not get pregnant. We have pathologically proven endometriosis, and all the data has been shown that endometriosis is poisonous to the egg, to the embryo, to the sperm, and also prevents implantation.
Good morning, Dr. Beck. How are you?
Hi, good morning.
It's finally nice to meet you. We see so many of your patients. They speak so highly of you.
Oh, thanks. It's nice to meet you.
Nice to meet you. I think one of our patients is asking this question as well. Can you explain further? Like we have seen with research that endo does affect euploid embryos, and there, people who are harvesting these embryos, they can be abnormal if you have endometriosis. Can you delve on why that is? Why does endo cause that to happen?
Sure. So what endometriosis can do is it can age your ovaries more quickly. And by aging your ovaries more quickly, how does it affect the eggs? Well, it's a machinery of the egg that has to divide normally to get a normal or genetically normal embryo. So if that membrane of the egg is a little bit more fragile because you have an underlying inflammatory environment, which is caused by the endometriosis, that would affect it. Oftentimes, if I know someone has endometriosis, I always trigger ovulation smaller because I know that their eggs will mature potentially at a smaller age. Who matures smaller? Women who, as they start to get older, they'll mature smaller, or if they have endometriosis or any type of autoimmune issue, their eggs tends to be a little bit more fragile, they mature at a smaller size. And so when you do IVF, if you know someone has endometriosis, I always try to trigger at a smaller size so that the machinery of the egg will divide normally, and that's why. And so even if someone has endometriosis and they don't have a lot of follicles, first of all, usually I don't recommend they do egg freezing because I really worry that they're not going to freeze and thaw well, and I don't want to simply go through the motions of it. But if we're doing embryos, even in the scenario of an embryo and you do genetic testing, if someone has endo, people always want to do IVF first. But if we're doing harvesting for the future, I do recommend having the surgery first so that their eggs have a better chance of being normal, responding better to the medication, and so that we have a better chance of getting normal embryos.
Right. And that is the question with a lot of our patients who come to us with infertility, that they are always asking us, should I go ahead and harvest embryos or eggs, then go through surgery in case my ovaries get damaged? And I had looked at some research, and I actually ended up publishing it at ASRM. We looked at about 40 patients who all had endo on their pathology, and before surgery, they were all trying to conceive for about 29 months. And after surgery, they were all able to conceive within 4 months, and all 40 of them were able to get pregnant by embryo transfers, but they shortened that time after surgery. So Absolutely.
But
I
the
totally
one
agree with
caveat
you.
of that is you have to make sure it's someone who doesn't have adenomyosis, which is endometriosis in the muscle. That you have to separate that category. And so that's one of the things that Dr. Najat will identify. There are times that when he does surgery, even in someone who's completely asymptomatic, if they have adenomyosis that's in the muscle, I do bring up surrogacy. It's not a fun topic. It's not a, you know, patients are a little shocked, but if you have it, it's better than if they really want to have a genetic child. Those embryos are so precious. So I do want you to know that it's not always the case where if we have a normal embryo, we have surgery. There are times that we learn things intraoperatively that tell us you shouldn't carry a pregnancy. There was a very young woman in her early 30s, Dr. Najat may recall her, and she was asymptomatic. Her and her husband did not believe that they had any issues. When Dr. Najat went in, her entire pelvis was a concrete, and he actually called me to tell me, this is not correctable. I don't know if you recall, but you called me intraoperatively and said, this is not correctable. And we moved on to surrogacy, and they subsequently have 2 genetic children with surrogacy. But obviously this is an asymptomatic woman who is not expecting this, who went like not willingly for surgery, but then when we went in for surgery, she was so grateful that, you know, even Dr. Najat couldn't correct this. And so, you know, I do want you to know it's not always that we just tell people, oh, you're going to be able to carry pregnancies. But what we do learn intraoperatively with Dr. Najat is whether or not you can, and we're not going to waste an embryo. And then the other thing that I want to identify is that it's not simply having endosurgery. Who does your endosurgery, that they're doing an excision therapy, that they're trained in this, really makes a difference. My biggest concern is there's a lot of people who claim to be endosurgeons who unfortunately burn. And when they burn the eggs and they burn the endo, they're not excising and removing the endometriosis. They're not changing the environment. And usually when you burn the eggs, you're burning microscopic eggs. So you're usually putting women to menopause earlier. So I'm very careful. And so whenever patients are upset that I really only refer them to a couple of surgeons, there's a reason why. So I just want you to know, like, I want to make sure it's not just like telling everyone go get endosurgery, because I don't think that's the answer. It's who you do it with and making sure that it really fits along with where your fertility goals are.
What Carly is very smart about it, she found Dr. Beck, who is brilliant in her work, and she is the expert. And Carly listened to the expert in her area. And although other physicians may mean very well, they have good intentions, it might not be their finest moment of practice because that is not their area. So that is what I wanted to show. And also one area that it is important is the endometriosis that which, as Dr. Agrawal mentioned, many, and I think Roya was mentioning earlier that about 70% of the patients, it seems recently our data has shown that a lot of these patients, their chance of pregnancy is significantly even higher, but they have a lot of them go through IVF. I mean, especially if you are older, if your age group is higher, after about a period that we usually after surgery, perhaps 6 weeks, or every patient is different, they could go through the process of IVF, and the chance of success with IVF and implantation is significantly higher. And now Carly and Roya got lucky, got pregnant spontaneously, and Dr. Beck recommended to them to wait. And during that period of wait, when you listen to your physician, but some cases they have to go ahead and proceed with IVF and the embryo transfer. That is important. And I wanted to see how Dr. Beck decides which patient do you recommend to them to try on their own, and which of them, Dr. Beck, you proceed and you transfer the embryos.
So if there is endometriosis or they have a uterine factor. So if there's a uterine factor, 100%, I'm going to have them try it on their own as long as the tubes are healthy and the sperm is normal. Because if there's a uterine factor, you know there was no way they could have gotten pregnant. So if you have polyps, or if you have a uterine septum or fibroid in the uterus, this entire time they were trying, there was no way they would have conceived because there was no place to implant. But in anyone who, when I advise they consider trying to conceive on their own after surgery, I don't like rush people in, is I need to make sure that their tubes are healthy, they don't have endometriosis affecting their uterus, and the sperm is normal, because 30 to 40% of fertility is male factor. So I'm not going to have someone try in vain if the sperm's not going to meet the egg.
Yes, thank you very much. Again, this is very, very important that, when there is a combination factor of endometriosis and also male factor, that is why the rate of infertility increases. Sometimes the female partner has no endometriosis and the sperm count is a little bit low, she would get pregnant. Or sometimes both of them, they have a little bit of endometriosis and a little bit of sperm problem, then the infertility is exaggerated. So these are all factors that we evaluate, and the recommendations, it is Dr. Beck's recommendation. Our recommendation is individual. It is not a cookie cutter. Every patient is very different. Deborah, go ahead and please ask Dr. Beck.
Yes, good morning. Dr. Beck, it's so nice to meet you. We've really been looking forward to this. And Carly and Roya, thank you so much for sharing your stories. Your children are beautiful.
Thank you.
So, Dr. Beck, we actually have a question from one of the participants in the chat, or one of the people here with us today. You mentioned about the EFT, and one of the things that we often hear from patients is, why didn't my OBGYN recommend this? Is this something that they can do? Or is this only something that Dr. Najat or Dr. Beck can do? Can you tell us a little bit more about how that process works?
Sure. So with the endometrial function test, as with any of the uterine biopsy tests, it's not something that most OBGYNs will be doing. And the reason for that is if you're doing the ERA, which is a different test called the endometrial receptivity assay, it's very time specific, where when you start the progesterone, you have to do the biopsy 120 hours later. And so with most OBGYNs, with the volume of patients that they have and the timing, it's not going to be accurate because they usually aren't able to do it at the right time. For the endometrial function test, I'm going to be honest, this is something that I've seen even other fertility specialists have reached out to me asking how to do it, because they still are confused of how to do it. And so it takes a little time, and you actually have to read and work with the doctors at Yale to figure it out. Because normally when we start progesterone suppositories, you normally start at 200 milligrams. And with the Yale protocol, it starts off at 25 milligrams, which is 1 AP amount. And so you have to find a compounding pharmacy that can do this. And you also have to understand that we don't do blood work. The whole purpose of the endometrial function test is to know what's happening at the level of the uterine lining. It's microscopic. And so, because most doctors are so used to, if you read the textbook, you're going to do estrogen, progesterone levels, and they think that, oh, the levels are too low, I'm going to up it. And they don't follow the pattern that's recommended by the lab that created this test at Yale. The second thing that I'm really careful about just telling people to do with your gynecologist is that when I do the biopsy, I use a Pipel biopsy that's a straight plastic catheter that has no teeth on it. It can't cause damage. It can't cause scarring. And it's really how you do it. I go in with a full bladder. I do it under ultrasound guidance to make sure I'm getting the right tissue, because all tissue is pink. Because most doctors, when they do an endometrial biopsy, and you're usually doing it for cancer or irregular bleeding in a gynecologist's office, they will use a metal biopsy that can bend. You can get into the uterus easily, but it has teeth on it. And what's the downside of that? Well, if you have endometriosis, you have an inflammatory environment, and you have a biopsy with that, you may have had no uterine problem. And now after this biopsy, now it's scarring inside the uterus called Asherman's, and you are now going to have a difficult time getting pregnant. So it's not something I encourage everyone to do, because if you do it just to go through doing the test, but it's not done appropriately, or you have, even in the best hands, it's how your body responds because they used an instrument that can actually cause scarring. That's why I'm really hesitant to advise people to do this with a generalist or a fertility specialist who isn't familiar with it, because it can cause harm.
Thank you very much. person who addressed many of the questions of the audience and participant is Dr. Christopher Vermeulen. Dr. Christopher Vermeulen, as I mentioned, he is a naturopath and internationally known, and also the author of the book of Happy Hormones. Please, Christy, go ahead and answer the questions addressed to you.
Hi, everyone. Thank you for having me. So one of the most common questions I get with my endometriosis patients, well, first of all, I see a lot of endometriosis patients that come to me as a last resort. They've been struggling for years with painful menstrual periods, painful intercourse, heavy bleeding, chronic pelvic pain, bladder pain before their periods. And they've been struggling for years. And because, you know, endometriosis is not a readily diagnosed condition. So one of the first steps I always do when I'm suspecting it is refer to Dr. Najat. He's in the Bay Area where I work. And then we really get a confirmation about if it's indeed endometriosis or not. I recommend the majority of my patients go ahead with the surgery with Dr. Najat. And then the next step is really, okay, what do we do next? You know, we have the hormonal control options to keep endometriosis suppressed, or we have the natural options. I do have a lot of patients who can't take the hormones. They've had side effects with the birth control pill and the IUD. So then we go into a lot of the natural therapies. And, you know, there isn't just one single natural therapy when we're looking at suppressing endometriosis. It really does need to be a holistic approach. You know, it has to include dietary changes, which I'll talk about, lifestyle changes as well, supplementation with, you know, different herbal formulas like Beth was speaking about. She does a lot of the Chinese herbs. I do a lot of more of the pharmaceutical grade supplements. And then hormonal therapy, the bioidentical therapies, I use quite a bit. Women tend to have much less side effects with the bioidentical versus some of the other ones. And I'll go through and explain some of that for you. But I just want to get across that it really does have to be a multifactorial approach when treating endometriosis. So diet, you know, this is one of the key foundation for preventing endometriosis recurrence. And what we really want to look at here is decreasing inflammation in the body, because we know endometriosis, the pain, the symptoms all worsen when we're in an inflammatory state. So it needs to be more of an anti-inflammatory diet. And we also need to address the source of estrogens in the diet. There's a lot of chemicals in our environment and in our food that are termed xenoestrogens. These xenoestrogens, they can actually mimic estrogen in the body and stimulate estrogen-like effects. And I have seen these xenoestrogens actually increase serum estrogen levels in my patients' blood results and worsen endometriosis pain. So diet-wise, you know, it's decreasing inflammation and taking out any hormonal impacts from the xenoestrogens. So really like a plant-based diet, low in animal products, like low dairy, low red meat, and yeah, low dairy, low red meat, low sugar, as well as really the way to go. Taking out sugar significantly decreases inflammation. And sometimes just with that, I see patients' endometriosis symptoms improve. And this means if you look at the nutritional label on the back of any food you're eating, you'll see if sugar has been added to the ingredient label, and you'll see the number of grams. Ideally, you want to try to keep your sugar intake below 25 grams per day. And I see it a lot, you know, we're already
hard to do
by breakfast. When we look at granola, yogurt, different types of cereal, we're already, 15 grams already by the time breakfast is over. So we have to do a lot of work, with really focusing on a whole foods diet where you're eating real foods. You're not eating much that comes already packaged or in a box, because that's where the sugars start to sneak in. Red meat is important to take out because the beef here is not only treated with hormones and has estrogen in it, it's also very high in something called arachidonic acid. Arachidonic acid feeds directly into our inflammatory pathways. So again, like taking out red meat and sugar, you can already have quite a big improvement with some of the endometriosis symptoms. And then if you take out gluten and dairy products on top of that, even better. A lot of research has shown that by taking gluten out of the diet, your endometriosis symptoms can reduce up to 65-ish%. And this can be from a few different reasons. Gluten, one, causes inflammation itself. It's quite a big molecule for our body to digest and tends to activate our immune system. But a lot of gluten-containing foods also have a ton of sugar in them. So it's kind of two-pronged. The gluten itself is a problem, but also the foods that contain gluten tend to be a problem. So when you're hearing a lot of no's from me, like no dairy, no sugar, no gluten, no red meat, you really want to kind of change the mindset away from all the no's to, like what can I eat? What should I eat? And this is where you really want to focus on the whole foods. Like for instance, breakfast, instead of having granola or cereal, think about doing, whole grain oatmeal, for instance. And instead of adding sugar, you can add some fresh fruit to it and use almond milk or oat milk. You want to make sure that at least your lunch and dinner, half of your plate is veggies. These vegetables are so important. And it's not just because they're healthy for us, but they also contain a lot of fiber, which is going to bind up excess estrogen. It's one of the key things that I do with my endometriosis patients is try to reduce estrogen. And by having more fiber and plants in your diet, it's going to help bind that up and help take some of that estrogen out of the body. The vegetables are also very high in antioxidants, which are going to help decrease inflammation. And also by adding in more veggies, you're not going to be eating as many of the foods that have the sugars and the dairy and the gluten in them. So if you could focus on a healthy breakfast, either like whole grains, oatmeal, do like a protein shake. However, protein shakes, we've got to be careful of too, because a lot of that protein powder is either whey protein, which is a dairy product, which can worsen inflammation and increase estrogen, or they're also soy. And I know I've received some questions about soy protein. And there's so much debate whether soy is good or bad and whether it increases estrogen or not. From what I've seen in clinical practice, I think it's a problem. I have at least the highly concentrated soy. So soy that's found in protein powders and bars are the ones that I see cause the issue. Having like tofu and tempeh, I haven't seen an issue with endometriosis and estrogen excess symptoms, but definitely soy protein bars, I have. I've seen it I had one patient, her serum estrogen levels went from about 150 in the luteal phase, so that the weeks leading up to your menstrual period, up to 400. And once I took out the soy protein, so the difference was went 150 to 400 because she added in soy protein. Once I took out the soy protein powder, it dropped back down. So I have seen it clinically with that high concentration of soy products. So yeah, diet wise, whole foods, half your plate, veggies is the way to go. Whole grains are lovely. Just because I'm saying take out gluten and sugar doesn't mean that you can't eat oatmeal, you can't eat brown rice, quinoa, couscous has gluten, so that one's still out. But there's a lot of whole grains that you can still eat and enjoy. But definitely plant-based, low sugar, low dairy, no gluten. So that's kind of the diet component. One question I get along with diet actually is about wine and alcohol. Same thing with wine, like, yes, red wine has resveratrol in it and some antioxidants, which are great, like we all need a little bit more antioxidants. But the problem with alcohol and wine is that the side effects of the alcohol outweigh the benefit of the little bit of antioxidants and resveratrol you get in the wine. There's every year, the cancer societies are releasing new research, and they do show that, especially for women, more than 2 alcoholic drinks per week does increase the risk of heart disease, colon cancer, breast cancer. And alcohol itself also increases estrogen levels in the body. So, you don't have to take alcohol out completely, but limiting it to 2 drinks per week, I think is the better way to go, for sure. Okay, so that's kind of the diet component. That's super important when we're trying to suppress endometriosis. One of the other key parts is lifestyle. And lifestyle is a big thing. This involves exercise, it involves stress reduction, it involves your environment and its toxicity. So we do see that stress affects our immune system and our inflammatory system. And I have clinically seen that high stress does worsen endometriosis symptoms. And yes, easier said than done. How do we, we live it, we all have stress in our lives. But sometimes there's little tools that you can do that will help your body cope a little bit better. And some simple things would be, set up some predictability for your body, like give yourself some routine. So your body knows what to expect every day. So eat your meals at the same times, go to bed and wake up at the same time, exercise at the same times. If you can do that, it does bring down your stress response because your body knows what's going to happen to it next. Some other things, especially now during the pandemic, what I've been hearing from my patients is that they have no separation anymore from work and personal life because majority of people are working from home. And that's not good. We need to be able to set boundaries when it comes to our work and our personal life. So one thing to reduce stress would be also, have your set work hours. And that's it, leave your evenings free if you can. And if you can't, then you got to leave some time for yourself in the mornings and take a lunch break, give your brain and your body a bit of a break. And your colleagues, your bosses, they get used to it. They're say, okay, like I know you're not working during these hours, but I know that you're going to take care of it when you're back on at this time. So it also provides some good expectations between you and your colleagues to have set boundaries when it comes to work hours. And then of course, taking care of ourselves, especially for women, I find that we're the last, we take care of ourselves last, everyone else kind of comes first for us. And I think it's really important that we still, even if it's, 15 minutes a day, we're still doing something that brings us joy, that we like to do. So really, I encourage all of you to really think about what brings you joy and try to sneak some of that into your life every day. And yeah, and what doesn't bring you joy, as we overcommit, we all do. Also go through and create a list of everything that you're doing and see what makes you happy and what doesn't. And if there's things on that list that you really don't like doing, get rid of them if you can. Of course, we can't get rid of everything we don't like, but try to make some changes there.
Thank you very much, Christy. That was very, very insightful, very helpful. Thank you very, very much. That is very wonderful, all of your advice, and we appreciate it.
Uno de los grandes logros que se ha logrado en endometriosis es el Worldwide Endometriosis March, el EndoMarch, que su fundador, el doctor Karam Nizad, ha logrado por más de 70 países a nivel del mundo, donde hemos llevado la información precisa y exacta de lo que es la enfermedad, lo que es la endometriosis. Este ha sido un trabajo muy grande, donde muchos médicos, los cuales el doctor Nizad ha reclutado y ha llamado personalmente para apoyarlo y formar una red de médicos en los cuales nos estamos difundiendo la información adecuada, buscando pacientes con endometriosis para darle toda la información correcta, para que no vuelva a pasar lo que estamos viendo nosotros en nuestros consultorios, pacientes que llegan sin ovario, que llegan con muchos problemas destructivos por cirugías y tratamientos que no fueron los correctos. Esta fundación, el Worldwide Endometriosis o el EndoMarch, su objetivo es concientizar a las pacientes, concientizar a los médicos y en un momento lograr que estas pacientes tengan el tratamiento correcto y adecuado para tratar la enfermedad con las menores secuelas posibles. Nuestro objetivo es que esta información llegue a todo tipo de paciente que sufre esta enfermedad. Recordemos que esta enfermedad es más de 200 millones de mujeres en el mundo, que esta enfermedad tarda entre 7 y 10 años en ser diagnosticada y es muy importante que el médico, desde que llega la paciente con todos los síntomas, pensemos en ella y la tratemos correctamente. Hay que agradecer y aplaudir esta labor que ha hecho el doctor Nizad a nivel mundial y muy honrado de que me haya nombrado como director de su programa en Venezuela, en el cual vamos a servir muy fielmente para que estas pacientes tengan la información correcta en cada momento y en cada segundo. Nosotros aquí en el centro médico logramos tener un posgrado, tenemos gente que estamos entrenando todo el tiempo para sacar médicos que puedan diagnosticar y tratar la enfermedad adecuadamente. Tenemos investigación, hemos escrito documentos, hemos escrito libros, hemos escrito papeles, de tal forma que esa información llegue siempre a las pacientes y que también los médicos tengamos una educación continua para que este objetivo se logre. Así que quiero felicitar a este proceso, estamos todos muy comprometidos. En nombre de Dios, la endometriosis va a ser una patología que cada día va a ser más concientizada, mejor estudiada y mejor tratada para todas estas mujeres. Tras 30 años de trabajo en esta enfermedad en endometriosis, hemos logrado aquí en Venezuela formar un centro médico, el Centro Médico Dr. Abdala Karame, donde tenemos todas las especialidades que podemos nosotros tratar a esta paciente con endometriosis. Tenemos un equipo multidisciplinario donde tenemos cirujanos, gastroenterólogos, urólogos, psicólogos, psiquiatras, nutricionistas, enfermeras especializadas. Tenemos un programa de entrenamiento constante, residentes que entren y en 2 años los entrenamos a tratar esta enfermedad, tanto médicamente como operarla. Tenemos la parte reproductiva, donde no únicamente tratamos la parte del dolor, sino también tratamos la parte reproductiva. Tenemos una investigación continua, estamos haciendo todos los días investigación, estamos buscando nuevos logros, nuevos tratamientos, nuevas técnicas para que estas pacientes cada día sean mejor tratadas. My name is Abdallah Karame. I'm an endometriosis specialist. I've been working more than 30 years in endometriosis. I'm so happy that Dr. Karam Nizad, he named me like a director of his program in Venezuela. It's EndoMarch, and we are so happy and proud to be part of this procedure. We're working in Venezuela in endometriosis. Forward we go.
Endometriosis is a chronic inflammatory disease that is estrogen dependent.
And basically, it consists of the presence of endometrium-like tissue, the same tissue that sheds every month during the period, can be implanted on different organs inside the body, such as the ovaries, the fallopian tubes, the uterus, bowel, bladder, and other organs. Endometriosis affects between 5 and 10% of women worldwide. It is very important for patients who are suspected to have endometriosis symptoms to seek consult with an endometriosis specialist, because not all gynecologists are trained to deal with this pathology. The diagnosis of endometriosis is made based on symptoms when patients are symptomatic, and a physical exam and imaging. Women with endometriosis can be complaining of painful periods, which is the most common symptom, and they can have the pain starts before the period and worsens during their periods. They can have pain with bowel movement if it's involving the bowel. They can also have diarrhea or constipation that worsen during the time of their menstruation. They can have blood in the stool. They can have urinary urgency and frequency, and sometimes pain with urination, especially around the time of their period. They can also have painful intercourse, and sometimes if there's involvement of the lungs or the diaphragm, they can have chest pain, and they can have problems with breathing around the time of their menstruation that happen in a cyclical fashion. And they can have infertility as well. Typical imaging that is needed for diagnosis include ultrasounds of the pelvis or MRI of the pelvis. Imaging can be tailored towards symptoms, and sometimes abdominal imaging and lung imaging can be required depending on the patient's symptoms if there is suspicion of involvement of other organs. Even if a patient has normal imaging, such as a normal pelvic ultrasound or MRI pelvis, they might still have endometriosis that is superficial and is not seen on imaging. And for those women, the mainstay for diagnosis is a diagnostic laparoscopy. Failure to treat endometriosis in a timely fashion can lead to a chronic pelvic pain syndrome, where despite treating the endometriosis at a certain point, the pain doesn't resolve completely even after excising the endometriosis, because the nervous system becomes very sensitive to pain stimuli despite the absence of the disease. The mainstay of treatment for endometriosis is surgical excision, and usually this should be done by a surgeon who is trained in the treatment of endometriosis. Surgery is usually tailored towards the desires of the patient, whether the patient is seeking fertility versus is seeking treatment for her pain, or both together. And the way surgery is done is really dependent on those two factors. Surgery involves excising all the disease from all the organs that are involved, which could be sometimes bowel involvement, bladder involvement, ovarian involvement, diaphragm involvement, or liver, or any other organ in the body inside the abdomen, and sometimes outside the abdomen, such as the lungs. So surgical treatment is multidisciplinary and sometimes can involve a colorectal surgeon or a thoracic surgeon or a urologist, depending on the organs involved with the disease. Other modalities of treatment include the use of hormones, such as progesterone, or some of the hormones that suppress the secretion of estrogen and progesterone from the ovaries, which are known as GnRH antagonists or GnRH agonists. They can help decrease patient symptoms such as pain, and also they can help decrease the chance of recurrence of the disease, especially after surgery. So they can help consolidate the result of a surgical excision of endometriosis as well. It is very important to understand that those medications do not cure the actual disease. In addition to surgical and hormonal treatment, other treatment modalities are involved, including use of medication for chronic pain, as well as behavioral changes, dietary changes, and treatment of associated pathologies such as bladder pain syndrome and myofascial pelvic pain that are commonly associated with endometriosis, and that can sometimes involve pelvic floor physical therapy. Endometriosis is a chronic disease and can recur despite medical treatment and surgical treatment. There are many things we still don't understand about this disease, and hopefully more research are currently being done in order to better understand it and better serve our patients.
Good afternoon, and thank you so much for joining me. My name is Gerard Polian, and I am a worldwide EndoMarch headquarters volunteer. And today we have the EndoMarch representative from Team France, Priscilla Cerezo, joining us today. Thank you so much for your time, Priscilla. How are you doing?
Good. How are you?
Oh, everything is going well. It's a pleasure to talk to you. And hopefully I'll be hearing about the many accomplishments Team France has done. Well, we're excited to announce that Worldwide EndoMarch is celebrating its 10-year anniversary, and throughout these years, many efforts have been made all over the world to increase advocacy and involvement to fight endometriosis. Now, Priscilla, I was wondering if you could give us a rundown as to how Team France's efforts have furthered endometriosis awareness in your area, and if there have been any specific events in France that have been particularly successful.
Of course, for us, so Endoma in France is an association of patients. We are going to celebrate our 10 years anniversary too in 2024, so it's pretty exciting. From 2014, we have made such a big difference so far. Back then, it was really hard to just, have an article on a journal or something talking about endometriosis. Today in France, we have 1 media per day talking about endometriosis, which is just huge and everything. But we are really focusing on not just doing sensibilization around the disease, but also looking for what we can do to make it better every day for the patients, what they can do in their life around treatment or around different tools that they can use to have a better quality of life. The different events that we had so far that have been very successful are obviously the EndoMarch, because it's really powerful for the patient to be around, to be able to meet and talk about the disease. And also we usually organize a big conference this day, so some doctors can come and talk about it. We also organize since 2018 the Endo Run. So it's a run that we can, with which we are raising funds for research. So we've done two years in a row in Paris, but after that in 2020, we had to go virtual because of COVID. So we did 3 years in virtual, but it's been very successful because we raised 50,000 euro last year for research. So it was pretty amazing. So in 2023, we are doing both virtual and a race in Paris to raise more money for research, and also have an event so people can be together, discover different tools with partnerships around the event. So it's always very good event for us. We are organizing all through the years also some conferences all around the country to make sure the patient have all the information and they can get sensibilization. We also organize sensibilization in different schools in order to sensibilize the teenagers. And it's very important to have a different way of talking about endometriosis to the teenagers, because hopefully they won't have the same impact as the women who are now 30 and 40, who had 10 years delay, and with all the consequences that come with it. Also, we are doing some works in different companies around the country. So we go in the companies, or we do webinars where we do sensibilization and trying to find some tools and things that we can implement in the companies in order to make it better for the employees, but also for, well, employees that are suffering from endometriosis, but also employees that have someone in their family, either wife or, you know, their parents from teenagers with endometriosis. So it can be better for them to have adjustments in their work. So that's around all the events. We also do workshops with health professionals, in which it's a whole program where patients get in the program and get different workshops where they can start with understanding endometriosis, understanding all the treatments and how pain works too, because it's very important to understand how the pain works. And also then they have different workshops where they can get some access to tools, either on, you know, what we can do in sports, or like the emotions, and also with food, pretty much everything you can do, because there's so many things that you can do, but it's the most important is to have access to the information. That's what we do, and it's free for the patients, thanks to the French government that is taking care of this. I think it's pretty much it on the different event that we have.
So I'm glad that all of your events have gone well, and specifically for your Endo Run event, you know, COVID has impacted a lot of events pretty badly, but I'm glad that your event seemed very successful during COVID when it was online, and now you'll have an in-person and online resource, and that will give you the ability to outreach to more people. So congratulations on your successes. One thing I was really intrigued by was you said that you're outreaching to students, and I was wondering how you're specifically conducting student education for the younger audiences.
So we had some money from the government to develop a big campaign toward the youngest, toward the teenagers. So we created those. I think we can call it pack, where you have some flyers, you have some small books, you have some I don't know the word in English, but it's sorry, we can start again. How do you call it? You know, like a big paper that's like this that you put on the wall?
Like a poster.
Yeah, okay. Oh, sorry, start again. So we got some money from the French government to implement a program toward the teenagers. So we developed some pack for the different schools where you can have flyers, small books, and posters there that they can put in the different area of the school, especially in places where they go when they are sick. So it's like we have small clinic in different schools, but it's just like one nurse in there. When you are sick as a student, you can go there. So the nurses, they can, you know, give the different papers to the girls who go there and have pain during periods, because, you know, they can think maybe it's endometriosis. We are trying to include in it endometriosis and dysmenorrhea, because we know it's really hard to get a diagnosis there at this age, and it's not always endometriosis, but the most important is to have the pain managed at this time, endometriosis or not. So we are doing this. We're trying to put it in every school in France, which is a challenge because it's a lot of logistics. And we also developed some presentation. So we did something that's called info in talks. I don't know if it's all right in English, but we put information, and the student, they have to vote either if it's true or false, basically. And it's been very successful. Especially we have seen boys very interested in answering the questions. So it's very nice to see that this population is very looking for answers. Even if sometimes they are wrong, it's okay, because we're trying to make it as playful as possible so they can, you know, stay focused. And we are also developing a campaign online, so especially on TikTok, because we know it's the one social media of this generation, trying to make videos that are, playful, but also educative and with very good information so they can, stay connected, get some information, and know what they can do. And we are doing also the workshops specifically for the teenagers in different, area of France with some health professionals. And we are not putting the teenagers with the people who are more than 18 because we feel like it's not the same way of talking about endometriosis. So we are developing specific workshops for them.
Well, that's fantastic. And that 7 to 10 year delay in diagnosis, one of the main reasons is because the public is just not educated on the existence of endometriosis. They don't even they won't even consider that as their issue because they don't know about it. So it's amazing that you're bringing this disease to the forefront of people's minds, especially the younger population. That's amazing. It's great to hear about. I also wanted to ask you, in regards to that diagnosis time, has that 7 to 10 year diagnosis time, do you feel like it's gone down throughout your years of efforts with Team France?
Well, the last time there was some numbers, it was about 2 years ago, and it's what was up to 10 years. But the thing is, we have some teenagers who are being diagnosed right now, which is a success. But I feel like it's staying at 10 years also because there are some women who are like 40 and 50 years old who are finally being diagnosed, which brings, the average really high. So right now I feel like it's quite hard to really have a number to really know what's going on because it's such a difference that is happening right now. And yeah, it's hard to say. There's still a lot of work to do with diagnosis because a lot of women, they still like do one MRI and this, like the doctor will say, oh, there's nothing there, it's in your head. So there's still a lot of work to do with the health professionals to have them have the right education with endometriosis, but it's a work in progress for sure.
Of course, it's a little bit early for me to be asking that question, but hopefully with all of your efforts, successful efforts that I've heard about, that time will go down much quicker as the years go by. Another thing I wanted to ask you about was finding an endometriosis specialist in your area. Have you heard from EndoMarch members in France that it's remained difficult to find a specialist for diagnosis?
So it's hard to say also because we have since 2022 the national strategy has been implemented in France. So a lot of things are work in progress right now. And one of the structure, like one of the ways it's going to be is that in every we can say state, I guess, in every state in France, we're going to have a specific organization. And this organization is going to identify all the health professionals that are educated in endometriosis and have a specialty in endometriosis. So for the patient, I think maybe in 2-3 years, it's going to be much easier to get an endometriosis specialist because there's going to be this different organization in every state. So you can just contact them and they tell you, okay, so this is what the symptoms that you have. You can go and see this doctor or this midwife, because we have a lot of midwife taking care of endometriosis in France. So yeah, it's a work in progress. It's getting better. We still have some places in France where we don't have any doctors. So endometriosis or not, it's very, very bad, which makes it very, very difficult. And some women have to travel like 700 kilometers to find a good doctor. But we are really hoping that with everything that is being implemented, it's going to be better. It's obviously better than 10 years ago, obviously.
Regardless of what the results are right now, your efforts are truly outstanding. And thank you so much for all of your efforts. And I just wanted to say once again, thank you so much for Team France's monumental impact towards endometriosis education, not only in France, but truly all over the world. Are
Thank
there
you.
any last words that you would like to add on behalf of everybody at Team France?
Yes, we are very excited about everything that's happening. We really believe that we can all work together to have a better chance of, like, having a better life with endometriosis. We've been working with, different countries right now in Europe, especially, but I think that by exchanging all the things that we get together, that we do in every country, we can just, find different solutions and go beyond and, make it better for everybody. So I feel like there is hope, even though if it's going to be probably like a lifelong job because it's never going to be perfect. There's always going to be some more to do, but it's really nice to see, to see back 10 years and realize everything that has changed and all the hope that there is. So, it keeps us going every day to make sure it's going that way.
Thank you so much for telling me about everything and all of France's success. It was amazing to hear about everything.
Thank you so much for giving me a chance to talk about it.
Oh, no problem. I hope you have a great day. Thank you so much.
Thank
And we
you
hope to
too.
hear about much more successes in the future.
Thank you.
All right. Bye-bye.
Bye.
So, good morning, good noon, good afternoon, good evening to everybody all around the world. I am Dr. Cameron Nejad. I would like to welcome you to another session of the Worldwide EndoMarch for the benefit of the young girls and women with endometriosis and their families all around the world. We would like to thank all of you for tuning in and listening. And we would like to thank all of our patients, our friends, the organizers of the Worldwide EndoMarch, the ambassadors, the captains, the presidents of each chapters around the world that since the inception of the Worldwide EndoMarch 7 years ago have significantly raised awareness about endometriosis, and they have brought endometriosis more and more to the forefront for the helping of millions and millions of women and young girls with endometriosis around the world. So we would like to thank you very, very much. These sessions, as you know, they have been very successful and very popular, and it is all because of you. Please let us know what you would like to hear and what sessions, and write your questions. We would announce them and we would answer those questions. Before we start, we would like to address a couple of very popular questions that often people are asking us. The next webinar will be in August the 29th, and the issues that we will address, they are going to be about adenomyosis and fibroids and their relationship also with endometriosis. And if you have any questions specifically about fibroid, endometriosis, adenomyosis, that it is very common with endometriosis, and any other specific question that you might have, we will try to address them again. It is going to be Saturday, August the 29th. Also, many of you around the world have been asking questions about the next year Worldwide EndoMarch. Next year Worldwide EndoMarch is going to be during the weekend of March 26th to 28th, and it is going to be virtual, and we will announce it later how all of you across the globe We will feature you, and you have time to present your achievements in your country, in your area, during these 2 days of live session, virtual, that we will organize it. So that is another announcement that I would like to make. And finally, I'd like to thank today's participants, our wonderful patients, Lily Cooper and her mother, Karen Zeltzer. Also, we would like to thank Marketa Janska with her daughter Stella and her husband Ryan, that they are two of our patients that they are going to express their journey and their experience with endometriosis and their travel with endometriosis. And of course, the Dr. Sarah Bracker from Germany, that she has been very kind. She is a leader in endometriosis and congenital abnormalities of the female reproductive organs, and in Germany she is the head of her department. She has joined us. And also we have Dr. Dorian Bosev, the professor at University of Sofia in Bulgaria, that he has done a lot of work, research about endometriosis, and he is going to address that. We would like to thank them. Also, we would like to thank our own organizers at the Worldwide EndoMarch headquarters, Zoe Pennington, Sean Stetner, Eliza, and in New York, Tiffany, that they have been very helpful with running the Worldwide EndoMarch. The founders of Worldwide EndoMarch, Dr. Fars, Sina Nejad, Dr. Azad Nejad, myself, and Barbara Page. Also, we would like to thank you for all of your attention and participation in this series. Saying so, we thought this time we start. There are several questions in respect to endometriomas and chocolate cysts and how to deal with it. At the same time, how women get pregnant and have children, patients who have had endometriosis and chocolate cysts and endometriomas, failed IVF. So each of them, I thought we ask Marketa to say a little bit of her journey. Marketa is one of our patients, and I let her tell her story, and then after that, we will proceed with question answers about some of the questions, and then after that, Lily would say something, and then some question and answer. So, Marketa, are you available to say something with your little daughter?
Yes. Hello. My name is Marketa Janska, and this is Estella. She's 10.5 months old. And my journey to conceive was difficult. We got married. Me and my husband got married in 2012, and didn't start trying until 2015. But it took us about 8 months of being unsuccessful to go to a fertility clinic, and she's gonna be she's a toy, honey. We did in a fertility clinic, we did 6 IUIs in the beginning, which took around 7 months, and then I did IVF, honey. And when I had we were lucky to get a couple embryos, and I was supposed to do the transfer, but I wasn't confident about my uterus because by that time I was in such pain during my period, and also during my treatment I felt like my uterus was just burning inside. It was just such a burning sensation, and I wasn't confident about doing the transfer with my embryos. And I asked my fertility doctor, Dr. Beck in California Fertility Partners, if there's anything else I could test for, or I was very scared of not being successful with the IVF with the embryos, and she said I could do this endometrial test, which will find out what the status of my my uterus is. I don't know how to describe it, but I did the test, and it came back a few weeks later that they have found the endometrial cells in my uterus, and that I have endometriosis. And I never realized, right? I didn't know about it. I had no idea. The only thing I knew was that I had really painful periods, and yeah, I just didn't know about it. I guess I wasn't aware. And she recommended Dr. Najat to schedule us to have a consultation and schedule a surgery. And I had my surgery November 1st, and I recovered very well. It only took me a few days, but it was pretty severe. He told me that it was stage 4, and I had it all over my bladder and my ovaries, in my uterus, my rectum, like basically all over. And he told me that we have a great, what was he saying? We have a great chance of conceiving, and we did conceive our daughter naturally month and a half after my surgery, and which was a huge surprise. And yeah, and here she is. So we were very, very successful with Dr. Najat's help, and we're very, very, very grateful.
Thank you very much, Estella. So, Marketa and Estella and Ryan, the issue is that we wanted to address is that a lot of time young women with endometriosis, the question is how to diagnose endometriosis. And one of the goals of Worldwide EndoMarch has been to find a way to diagnose endometriosis and how to find out how endometriosis is diagnosed. Right, there are some tests coming up, and like Receptiva and some of the endometrial assays. But at the same time, we want to let you know, Worldwide EndoMarch has been able to develop an app. That app is completely free, and you can diagnose endometriosis with the app of the EndoMarch with more than 90% accuracy, and that is available. So thank you very much, Marketa, for your experience and the issue of endometriosis and infertility. And here is our friend, the father, Ryan. Nice to see you, Ryan, with a baby. So please don't stay there. Some may have questions from you, and then when there is questions from you, Dr. Sina, Nejad, they will bring it up. So we will go, and there is one question that we would like Dr. Barker to address. It is, do chocolate cysts affect the function of the ovary? There is one question coming. Dr. Barker, as I mentioned, she is the head of the department at her program in Germany, and Sarah, welcome.
Yes, thank you very much, and thank you, Marketa, also for sharing this your history, because this is a very typical history, and the problem is that most of us as women have been told our long life that pain during our period is something normal. And I think it is very important, and therefore congratulations to the family, Nesat, for this awareness campaign that even young girls have not to be told that pain during the period or during sexual intercourse is something which you have to tolerate. And we have to look where is the balance between really, really minor pain and where is the pain so severe that we have to think about endometriosis. And your story, your history really tells us that pain is one of the most things we have to look at, but also, and this was the question what Dr. Nesat just asked me, that of course, if there is a chocolate cyst on one side, you could assume that this affects the functioning of the ovary, but not only the chocolate cyst of the ovary could affect the fertility, it could also affect if endometriosis, and if it's only a minor endometriosis, we would like to have it cured and resected before we try to get a fertility treatment. Because what you told us is often the case that once you have cured endometriosis for the moment, women get pregnant 1 or 2 months later. So this is the good thing about endometriosis. You could cure it for a while and you could get pregnant. But of course, if you have an endometrioma, so-called chocolate cyst on one side, this affects the functioning of this ovary.
Thank you very much, Dr. Baraka. The next question comes from one of the patients who is from Ireland. The question is, what are the signs and symptoms of bladder and ureter endometriosis? And that question is for Dr. Moser.
Hello, Cameron. Thank you very much. My name is Dr. Bosif. Do you hear me?
Yes.
Yes? Okay. I come from Sofia, Bulgaria. It's a very interesting question because urinary tract endometriosis is very rare, and it actually presents in 1 to 6% of all women that are diagnosed with endometriosis. The thing is that in cases of ureteroendometriosis, the patient typically has pelvic lesion that causes external compression, inflammation, and fibrosis of the involved ureter. The patient may present with vague symptoms that are not typical, like pelvic or back pain, renal colic, like silent urinary obstruction with hydroureter and loss of renal function. The genitourinary symptoms are flank or abdominal pain, dysuria, gross hematuria, uremia, and pelvic mass. So in some cases, actually, the symptoms are more common for endometriosis, like dysmenorrhea, pelvic pain, or dyspareunia. Actually, the lack of overt symptoms of endometriosis of the ureter makes sometimes this diagnosis very, very difficult. And although ureteroendometriosis, although ureteral obstruction of ureteroendometriosis is an uncommon condition, it is very important to put the right diagnosis and treatment in order to avoid the loss of renal function. On the other hand, unlike ureteroendometriosis, bladder endometriosis is usually symptomatic. Patients typically present with low urinary tract symptoms, including hematuria, dysuria, suprapubic pain, increased urinary frequency, and elevated intravesical pressure. Of course, this needs to be differentiated. What is the differential diagnosis of these conditions? Most probably, you have to do differential diagnosis with urinary tract infections, with interstitial cystitis, with bladder stones, or with menopause, or with neoplasms. So the diagnosis of the ureter endo is sometimes very difficult because the symptoms are not typical, they are not clear.
Thank you very much, Dr. Bosef. So in summary, those of you that if you think there is endometriosis, if there is blood in your urine or you have a lot of flank pain, then obviously you see an endometriosis specialist, they do a test, and they can evaluate your bladder and your kidney, usually with a CT scan and sometimes ultrasound. So the next question is for Dr. Sina Nejat, and when the chocolate cysts exist, there is a lot of controversy when to remove the chocolate cysts, not to remove them. So, Dr. Sina Nejat, when the question is, if there is a patient who wants to get pregnant, or if she doesn't even want to get pregnant, she has a chocolate cyst, when should it be removed and when should it not be removed? And what are the consequences of that removal or not removing of the cyst?
Thank you very much. Hello to everybody, all of our friends and patients and participants. And also I'd like to thank the panel for joining us. Now, ovarian chocolate cyst is a description by imaging. That's all. It's how you look at things. But when there is a cyst in the ovary, something is not right. For example, majority of the patients who do have chocolate cysts, they have extra ovarian endometriosis too. So, of course, there is low but potential risk of malignancy and other problems. When should it be removed? Depends on the experience and the skill of the surgeon and the patient's condition and her desire how to proceed. Risk factor, family history, these are all indication of endometriosis or cancer, etc. So it has to be individualized, evaluated, but I can address when it shouldn't be removed. That's the most important part that I address. A person who doesn't treat the ovary as a very delicate organ, that person should not remove the cyst. And the reason I'm re-emphasizing this, because unfortunately on the teaching, now they say ovarian cystectomy is an easy procedure and it's a teaching for the residents and the students. In my practice, it is completely opposite. Ovarian cystectomy requires the most experience of using microsurgical principle to avoid any damage to ovarian tissue and the follicle. I hope I addressed your question.
Yes, thank you very much. So in summary, for the ovarian cyst, it has to be individualized, and we have to make sure that if it is treated, it is done by somebody who is experienced, not to damage the ovary. The next question is for Dr. Brucker, that if there is a chocolate cyst in one ovary, like the right ovary, if the ovary, for example, in the right side has a chocolate cyst, is that cyst affecting the function of the ovary on the other side as well or not? That is the question for Dr. Black.
Yeah, thank you very much for this question. Well, if you have a chocolate cyst on one side, as Sina Nesset just told us, normally it's not the only place where endometriosis is going on. So normally if you have a cyst on the right ovary which has endometrium in it, and you call it then chocolate cyst, you have to be very careful in looking around in the whole abdomen or pelvis if there are other endometriosis lesions. And it could, of course, be that there is endometriosis on the other side. But as Sina Nesset told us, you have to handle the ovary very, very carefully and have to do a perfect preoperative diagnosis. And ultrasound is one of the most important things you have to do before you go into surgery. And then you can see if there is a cyst on the other side. And sometimes it's only endometriosis on top of the other ovary, which you could remove or coagulate, which depends as well on the individual patient. So if you have a chocolate cyst on the right ovary, be aware that there could be endometriosis all over the abdomen, even if you go upper towards the liver or the peritoneum there. And you should remove it if the first thing or the prominent wish of the patient is to conceive and to get pregnant. The other thing is if she has pain as her main symptom. So you have to differ between those two things.
Thank you very much, Dr. Braca. The next question is also for Dr. Bosev. Dr. Bosev, what is the most common area of endometriosis? Is it bladder more, or the ureter more, or the kidney? What is the incidence? Just tell us these three. Which one first, second, and third?
In patients with urinary tract endometriosis, the bladder is the most commonly affected organ, followed by the ureter, and then comes the kidney. With ratio estimated 40 to 5 to 1, or approximately more than 85% of the endometriosis is to the bladder, and 14 and something percent to the ureter, and less than 1% to the kidney.
Thank you very much. That is an excellent answer and very good, precise. Bladder, the most common, 85, and then ureter 14%, and only 1% kidney. The question for Dr. Farnejad is, when you remove endometriosis, when you excise ovarian cysts versus when you ablate the ovarian cysts or other endometriosis, what is the risk of recurrence? And also, does the diet, like gluten-free diet, has anything to do, and how could affect the rates of endometriosis? You have to, Dr. Farnejad, you are muted.
I'm sorry. Thank you very much for the invitation. It is a pleasure to be here. So the question has two parts. One part is the incidence of the recurrence of the endometriosis and endometrioma after the excision and ablation. And the other question is about the effect of the gluten-free diet. Overall, the incidence of the recurrence of the peritoneal endometriosis after complete treatment depends to several factors, including the patient's age, the severity of the endometriosis, and if the patient, after surgical treatment, received any hormonal suppressive therapy or not. Also, definition of the recurrence depends how you define it. If you define a recurrence of the symptoms, like pelvic pain, or patient become again infertile, or surgically you do another laparoscopy, for example, to see if the endometriosis has come back. So it depends, as I said, how you define the recurrences.
Thank you very much. So go ahead, please. I'm sorry.
Yes, I'm sorry. I just want to mention one more thing. One more thing was that also endometrioma, the original of this endometrioma, we have published a paper about it. Majority of this endometrioma coming from ovulation. That ovulation of the ovary combined with endometriosis on the surface of the ovary and on the pelvic side wall get together and makes it chocolate cyst or endometrioma. So if the patient, after the surgery, receives ovulation induction medications like undergoing IVF or IUI, and produces multiple ovulation cysts, these patients have higher chance of developing endometrioma compared to patients that does not want to get pregnant, and you put her on some kind of hormonal suppressive therapy like birth control pills and prevents her from ovulation, this patient will not develop endometrioma. The last part of the question about the diet, gluten-free diet, anything that decreases the inflammation could help the pain, but not affects the recurrence of endometriosis. That is a short summary.
Thank you very much, Dr. Parnijad. We appreciate it. The next question is, a patient is said that she has had endometriosis. That is for Dr. Brocker, the next question. She said she has had endometriosis removed from both of her ureters, and she is concerned about monitoring the function of her ovaries, ureters. She has heard that endometriosis of the ureter could cause silent loss of the kidney, and how should she be sure that her ureters doesn't obstruct and she doesn't lose her kidneys?
Yes, this is indeed a question which a patient could ask, but if it depends on the surgery, of course. It depends on several things. If, for example, the surgeon is very excellent and could have removed the whole endometriosis around the ureter, and if, for example, they had to excise endometriosis or fibroided tissue around the ureter and do a reanastomosis, and if the surgeon can tell that there is no sign of endometriosis around in the whole pelvis or the abdomen, then normally the risk is very low. And it depends also on the age of the patient. So you could say, okay, if she is in her 40s or mid-40s, you could put her on the conceptive pill, and then she could also have a minimal risk that endometriosis comes back. So it really depends on the patient, and it depends especially on how good and how perfect the surgery was done, so that there is no just superficial ablation of endometriosis, but really resective endometriosis done. And this must be sure, and the patient has the right to ask her surgeon how we removed really the endometriosis.
Thank you very much, Dr. Brocker. That brings us to a very important aspect that, endometriosis is very common, and endometriosis, when it is very severe, it could be far worse than cancer when you dissect it. When you resect very bad endometriosis, when you want to treat it surgically, bad endometriosis is more difficult than any cancer. And often we were doing a procedure on Thursday with one wonderful colleague of mine, an excellent colorectal surgeon, Dr. Cindy Kin, and we were removing endometriosis, and we were resecting a bowel in a patient, and we were discussing that this endometriosis could be worse than cancer in patient. And that is why you have to see a specialist familiar with endometriosis. And as Dr. Brocker mentioned, endometriosis of the ureter could cause silent loss of the kidney. And for you to make sure how you are not losing your kidney, obviously you have to be followed by the surgeon who did your surgery. And usually what we do in very bad cases, we follow our patient by sometime yearly ultrasound, as it was mentioned again, of the kidneys and the ureters, and sometimes a CT, depending how severe it was. And for now brings me to the next issue that I want to address, and I would ask Lily and the mom to chime in, is that a lot of time, even pain, and it is not normal. It is often we see young women in the office on a daily basis that they come and they say, well, everybody, her mother, her doctor, her teacher, they say, well, you are a young girl and the pain is normal when you grow up. This pain is going to be, when you get pregnant, when you have children, pain will be gone. And sometimes when you ignore the pain, it could get worse. And I'd like you to listen to one of the stories and share that, and that is going to be Lily and her mom, Karen. And we appreciate both of you being part of this panel. Please go ahead.
Hi, everyone. My name is Lily Kupa, and I am an 18-year-old patient of Dr. Cameron Najat. I am chronically ill, and one of the diseases I struggle with is endometriosis. My journey with endometriosis has been a long and a hard battle. And although endometriosis is very common, as it affects between 1 and 8 to 10 women, it often goes undiagnosed, and those seeking help are frequently dismissed. I began struggling with symptoms of endometriosis starting at the age of 14. I had immensely painful periods that were very heavy. I had daily migraines, brain fog, fatigue, insomnia, night sweats, dizziness, abdominal pain, GI issues, and urinary issues. During this period in constant pain with all these symptoms, my family and I had no idea what was going on. I saw 3 GI doctors, 2 gynecologists, a cardiologist, 2 primary care doctors, a hematologist, therapists, psychologists, and 2 sleep specialists before I was finally diagnosed 3 years later with endometriosis. During these 3 years, I was tested for very basic diseases through blood testing and easy visual exams. Because these doctors did not take my problem seriously, I was told the cause of all of my pain, all of my symptoms were anxiety. I was constantly told my pain and my symptoms were all in my head. I was told I needed to get help, that I needed to go to therapy, and that all of my problems would just go away. For 3 years, 1,095 days, I lived in horrible, debilitating pain, knowing that it was not all in my head. I missed hundreds of days of school. I missed social gatherings. I missed out on so much while at home, stuck in bed, doubled over in pain. My mom was spending hours researching possible causes and how to come up with endometriosis. While talking to her friend who had endometriosis about my symptoms, she said it sounded like endometriosis. Her friend had been a patient of Dr. Cameron Najat, and her friend had been a patient of Dr. Najat as a teenager and gave my mother his information. She made an appointment with him, and this sounds really cheesy, but my life changed, my world opened up, and my true journey began. I met with Dr. Najat. I sat in his office at his big table. I was very nervous and expected that he would just tell me my pain was in my head and to go to therapy. But instead, he said to me that my pain was real and that it sounded very likely that I had endometriosis. He did a vaginal ultrasound, and it showed me that I truly did have endometriosis. He cleared his schedule, and the following week, October 18th of 2018, I had my laparoscopy. The results showed that I had stage 4 endometriosis, that I was covering my bladder, my uterus, my rectum, and my bowel, and that my bowel had become attached to my cervix. It also showed that I had adenomyosis and cysts. This day proved that my pain was not and never was in my head. Dr. Najat was the first doctor who believed me and gave me a voice. Since this day, I have been diagnosed with 7 other disorders, and I'll finally explain all my symptoms that I started experiencing at the age of 14. The other disorders that I have been diagnosed with, along with endometriosis, are postural orthostatic tachycardia syndrome, complex regional pain syndrome, Ehlers-Danlos syndrome, visceraptosis, interstitial cystitis, pelvic floor dysfunction, and vulvodynia. Something that I have learned through this journey is that many other women who have endometriosis also have these other disorders, as they all connect in different ways. If you have one, you may be more likely to have another. Before I met Dr. Najat and was believed, I was in a very dark and deep, hopeless hole full of despair. After my diagnosis of endometriosis, I emerged from this hole with hope, with powerful information, and I found a community on social media of other girls with almost the exact same story as me, where they were not believed and their diagnosis was delayed years. I found light and passion in having a voice and spreading awareness, and since created an Instagram where I bring attention to these invisible illnesses like endometriosis, and am in the process of creating a blog. I hope to help other girls and women reach a place of acceptance of their disease, but not acceptance of their pain. A place where they can feel comfortable in their bodies and can strive and hope to do the best they can and feel like they are enough. I also plan to go to school to work in the medical field to give young girls a better experience from the beginning of their struggles to be heard and to be believed. I once saw doctors' offices and testing locations as a place of harm and as a place of trauma. Once I received my diagnosis and had a framework for understanding my body and my challenges, I can now work with doctors and be involved in the medical system, armed with the right diagnosis and surgical reports to back it. I will no longer feel lost and disempowered. Medication can now be helpful instead of a band-aid to some undiagnosed problem. Tests can give a possible answer. A doctor's office can be a place of support. I won't accept less, and neither should you. I have many bad days. I still struggle with pain and challenges, but I am stronger, and I feel better inside myself to get up every day and find something positive to hold on to. Today, this experience is one of those wonderful things to hold on to. Thank you very much for this opportunity.
Thank you very much, Lily, for your very courageous and for very kind coming to this program and helping other young women, young girls that they believe that it is not in their head and there is help for them.
Yes.
So I thank you very, very much. That is, and I'm glad you are doing much better. And Karen, how did you, what is this, or what is your experience? Please share with other mothers.
Yes, and thank you very much again for this amazing opportunity. And I know that Lily is a voice for girls and women who have had endometriosis, and I'm hoping to be helpful as a mom who was trying to navigate a medical system for my daughter when she was a young teenager. I know that our journey is really not unique, and that it's really much more of the rule and not the exception. And I found that the road to being believed and being diagnosed and receiving proper treatment is rife with medical trauma. And one of the most powerful ways to heal from trauma is through connection and empowerment. While I was watching my daughter suffer in horrible pain and have a multitude of different symptoms, I felt very alone and very powerless as I navigated a medical system that looked at each symptom in isolation and would refuse to explore how all these different symptoms could be related. The usual response that we heard time and time again was that Lily would be routinely dismissed and that her symptoms would be minimized. And as I took Lily from one doctor to another, each would suggest that not only was this anxiety on her part, but perhaps this was all because I was an anxious mother. They would be kind of begrudgingly give some treatment to target one symptom, and I continuously implored doctors to try to connect the dots, that I felt like there was really an underlying medical condition that was really at the root of all this, that connect all these symptoms and could give a real explanation. As a mom, I was routinely criticized and humiliated by doctors, by school administrators, who would give me a look or a tone that I was a very permissive mother to allow my daughter to miss so many days of school while I knew she was at home, doubled up in bed in pain. I had people who would be annoyed if I canceled plans because I didn't want to leave her alone. And I missed a lot of my own work, which left as a mom feeling like you could never do enough for everybody, and that somehow I was failing everyone. I found that shame and guilt were feelings that plagued me, guilt that I couldn't protect my daughter from pain. I couldn't protect her from medical trauma. With each dismissal, each emergency room fiasco, each negative comment, that it was all in her head. But as a mom, as worn down as I was and dreading each doctor's visit, I knew that we had to go on and that I had to continue fighting and advocating for my child. I knew she wasn't making this up. I knew she wasn't exaggerating. I knew it wasn't in her head. And then one day I Googled her current symptoms and up popped this word endometriosis. And I started to read about it as much as I could. And I thought, okay, this could be it. And I actually emailed all of the doctors involved with her care and suggested that this was at the root of all these symptoms, and they all ignored me. The final piece of the puzzle that allowed this situation to be solved was I had an opportunity to speak at a conference, which unfortunately would take me halfway across the US. And I felt horrible mom guilt leaving my daughter back home in pain when I traveled so far away. During the weekend, my co-presenter was privy to the many phone calls that I had with Lily, who kept reaching out to me in pain and wanting to talk to her mom. She realized something wasn't okay at home, and she asked, and I answered, and I began to explain what Lily was experiencing and how hard it was to be away from her. She then said something pretty amazing. She said, "That's exactly the story of my life as a teenager," and began to explain her experience with endometriosis. She shared her journey. I asked a million questions. And the most important question at the end was, what is the name of your surgeon? As soon as I got back to the Bay Area from the conference, I called Dr. Cameron Najat's office, and they were warm and welcoming, and they scheduled our consultation. Walking into Dr. Cameron Najat's office, everything was different than all of our other experiences with doctors. He was warm, he listened. He told Lily that it was not in her head. That was one of the very first things he said. He said it was not anxiety. He encouraged her to have a voice in the office, and he listened carefully. And he did something so giving and so generous, and it was something that I didn't realize how much I needed, how badly I needed. He turned to me and said these wonderful words. He said, "You are a good mother." These words filled my soul. He showed caring for Lily, and he validated her. And for the first time in years, I could breathe. I think I had been holding my breath all these years, and now I could exhale, knowing that someone was in charge, who was caring, who believed her, and who could help, and that I was no longer alone in this. I could just be mom instead of a full-time advocate and a full-time medical student at the online school of Google. I'll never forget when Dr. Najat came to me and my husband after Lily's surgery, immediately after her surgery, and told us that she had stage 4 endometriosis, that it was very aggressive for someone so young, and explained all the ways that it showed up wreaking havoc on her. He kindly suggested that I send surgical reports to all of the doctors that we had seen over the years to help educate them. I was very happy to send those emails. At first, I was very angry, thinking back to all the negative messaging that we had both gotten over the years. So I waited 2 weeks before I sent those emails out because I didn't want it to be a kind of revenge to those doctors who had been so wrong, so dismissive, so uneducated about women's health. I didn't want it to be, and I told you so. I knew that for my own healing, I needed it to come from a place of sharing knowledge and educating people who needed this education to prevent it from happening to any other young girl. And that was the beginning of my journey to try to educate as many people as I could about my daughter's struggle and about all the millions of women and young girls across the world who have this very challenging disease and have also a lot of medical trauma around not being believed for years. I also love the opportunity to empower and support Lily's voice that had been silenced and quieted for so many years. And we both feel that if telling one person can help them feel not alone and get the help that they need, this is really the silver lining. And as I mentioned, the journey was ripe with medical trauma, and healing has come rapidly for me as someone traumatized watching my daughter go through this process. And for Lily, Dr. Najat was really the beginning of healing of her body and her spirit. And then the connection to the enormous online community was the next stage of her healing. She shared these links and these posts. And I learned so much, and I felt not alone and one person involved in a fight, but as part of the many in this community. And today she is a part of this global community that supports, educates, and empowers one another. And knowledge, as we all know, is indeed power. And I cannot thank enough the doctors involved today for educating so many people, and also to thank the community that's engaged in watching this, because I know that you're not only here to gain knowledge to help yourself and help your loved ones, but also to spread the word and share this knowledge. And so I no longer feel alone and powerless, guilty and full of shame, but proud and honored to be the mother of a daughter who is a fierce and powerful endo warrior. And I implore you all to keep up the fight and make yourself heard and advocate for yourself and your loved ones. And to remember that there are hard days and many hard days. But when you are worn down, whether you're the patient or the mom or the caregiver or the family member, particularly if you're the patient, when you are worn down, please reach out to this amazing community that will always be there for you. Thank you very much for this opportunity to speak. It's been an amazing opportunity and a great honor. And yes, so thank you very much.
No, thank you very, very much to you, Karen and Lily. It is our pleasure and our privilege to have you. The issue that Karen and Lily bring up, it is not that medical community, they mean well, they have good intentions. The issue is, that is why we like to thank Karen, Lily, and all of you, the participant, whoever is listening around the world, especially the organizers of Worldwide EndoMarch across the globe, that you are trying to elevate the level of awareness. What it is not in your mind, your eyes don't see. It is not on the radar of many physicians about endometriosis, and it is not anybody's fault. It is so common that it has become part of the culture. But pain is not normal. We have been saying it for years. If it was normal, 10 out of 10 women that had pain, but they don't. So it is a good idea to evaluate it. There is hope right now, and we are, by yard is hard, by inch is a cinch. We are making progress that hopefully children of Lily and the daughter of Marketa, Stella, they don't suffer. There are more in the future. Hopefully we will find. There are scientists all around the world that are helping, as I mentioned. Good tests are coming up for diagnosis of endometriosis. And also we have, again, the app of the advice EndoMarch that could help those around the world. That is the free app that could help you diagnose endometriosis. And that brings me to next question to Dr. Sina Nejad. The question is, the patient is a 29-year-old woman. She has had infertility. She has had one miscarriage. She has very little pain, but she has a chocolate cyst. She has an endometrioma. She wants to know, if she has this chocolate cyst, does it mean she has endometriosis anywhere else? If you have a chocolate cyst and you don't have any other symptoms, do you have to have surgery again? Or in this specific patient, can she get pregnant again? Or what do you recommend for her, please?
Yes, thank you very much. This is a great question. And I'd like to thank Lily, Karen, and I have good news for you. Professor Sarah Broker has done extensive work on adolescent endometriosis and also anomalies associated with endometriosis. So there are many good doctors, not that the other doctors who didn't diagnose you are bad, but there are good doctors all over the world that they are advocating early detection. And I personally have the most admiration for Professor Broker for all of the good work she has done for the young patients. Now, to answer your question, I think if we played back what Marketa said with Stella and you saw the result, that's the answer to your question. Yes, patients with endometriosis, even though they have had miscarriage or they have difficulty getting pregnant, if they are appropriately treated, they have excellent chance of getting pregnant on their own. Back to your situation, I cannot make a specific recommendation without examining and thoroughly evaluating. But as Professor Baraka and myself we mentioned, when there is suspicion for endometrioma, there is a very high chance of having endometriosis in other areas. And as we know, endometriosis is an autoimmune inflammatory process that could affect fertility significantly. So please discuss it with your doctors. Make sure endometriosis is on their radar. But then when it comes to surgery, damage of the ovary could hamper fertility. So I would recommend if the surgery comes, please make sure the ovary is treated respectfully. Thank you.
Thank you very much, Dr. Sinanajad. Then the next question is for Professor Bracker in Germany, that if an endometrioma ruptures, is it going to cause more trouble and could it contaminate the rest of the abdomen? What are the consequences of rupture of a large ovarian endometrioma?
Yes, I think this is a question or a concern of the patient, but we do not know the cause of endometriosis. This is our current problem we still have, so we cannot say the endometriosis comes because of. So what we know is that if we have a patient, for example, diagnosed with fibroids or diagnosed with a malformation like a septum in the uterus, for example, or other malformation affecting the cervix or the uterus or the vagina, or as I said, we have patients with fibroids, with myoma. These patients have a higher chance to have simultaneously endometriosis, but only because a cyst rupture, that then you have a higher chance that this endometrium, which comes out of the cyst, develops at the other side, at another area, again endometriosis. I would say there are no data for it, but we should be aware that once you have been diagnosed with an endometrioma or a chocolate cyst, you have to be aware that you could have at the same time endometriosis at another area. And there you have to be very careful. But if the cyst ruptured, there is not a real higher chance that after, I don't know, 6 months, you will get again endometriosis. The only thing is that once you have endometriosis, it could come back. But if it comes back because of the rupture, there are no data about it.
Thank you very much. So there is in general, what Professor Bracker mentioned is it is endometrioma when it ruptures, there is no data, but I do want to let you know that it is a good idea to try to avoid and not let it rupture, and sometimes in some areas, because we see a lot of patients here from IVF labs that they try to aspirate the endometriomas, and when these endometriomas are full of thick blood, it's very difficult to aspirate them, and the endometrioma ruptures, and it causes, in our experience, has caused a lot of severe pain, and sometimes they get infected and becomes abscess, and patients they get admitted to the hospital, and then they have to receive a lot of antibiotics. So that is tried, not if it is a very large endometrioma, the more experienced the IVF physician is, not to rupture it, and if it ruptures right away, you should get to somebody who is very experienced, because if it stays there, the blood is a good source for culture and infection, and it should be really cleaned up as soon as possible. Otherwise, it could unfortunately get very worse, and we have seen it many, many times. So the next question is for Dr. Farnejad, that when you remove endometriosis and endometrioma, is it normal to feel pressure on your, if endometriosis is removed from your bladder or your bowel? What is normal pain and what is not normal pain? Normal pressure, pain pressure on the bladder, etc.
Depends to how deep the endometriosis was on the bladder or different part of the pelvis. Remember, after the surgery, the body has a reaction and there is some inflammatory process going on in the pelvis. So some sort of the pressure and discomfort is normal as long as the patient does not have a high fever to be sure there is no infection. That is the reason that we put the patient on anti-inflammatory medication. Not only it takes care of the pain, also decreases the inflammation. Also, occasionally, if endometriosis on the bladder and certain area or in the posterior cul-de-sac around uterosacral ligament is very deep and is resected, affects the pelvic nerve, and those nerves could have some effect on the bladder function. And we see frequently after we're doing hysterectomy, patient comes and has some bladder function irregularity, and frequently again is confused with bladder infection. It is not infection, and after a few months or few weeks, even this disappears.
Thank you very much, Dr. Farnejad. Dr. Professor Bosev and Professor Brucker, they are in Europe, and we appreciate very, very much your participation. It is late for you, and we thank you, and with all of your experience, we are very grateful. There is a question for you that Professor Bosev, is it how often after you remove an endometrioma, a large endometrioma is removed, how often after that you should have a post-op ultrasound to make sure the cyst is gone or the ovary is functioning well? How should be monitored post-operatively?
In my practice, I usually do my post-operating follow-up on the 3rd month, on the 6th month, and on the 12th month after surgery. So that's what I do in my practice.
Thank you very much, Professor Bosev. The next question is for Professor Brucker. When you do, when is it necessary to remove a part of the bladder wall for endometriosis?
Well, as we learned today, or what we should learn today, is when should endometriosis be totally removed regarding which symptoms? So if you have, the problem is what are the symptoms related to? And as you said, Cameron, endometriosis surgery could be much more severe and much more difficult than any oncological surgery, because endometriosis goes really or could go really deep into other organs like the bladder or like the rectum. So it is very important that before the surgery, you really talk and listen to your patient. What complaints and what symptoms do they have? And what is the main focus? Do they have pain, or do they wish to conceive immediately? So you have really to look if, for example, they have severe endometriosis in the bladder, but they have no pain at all, no symptoms regarding the bladder, you have to see how extensive you resect it really, because the bladder you will need. So if you have, you can remove half of the bladder without, well, having severe problems afterwards. But you have to talk to your patient before really carefully and tell her and really listen to her and ask her what type of problems she really have. And the good thing about minimal invasive surgery is that experienced surgeon can remove the bladder wall and reconstruct the bladder at the same time. You have to see if the endometriosis is close to the ureter, for example, and if you have to do a re-anastomosis of the ureter into the bladder. But these are all things you have to evaluate preoperatively so that you can really talk to the patient what could happen during the surgery, and that it could be that there is a need for remove half of the bladder, but that afterwards her symptoms are really relieved and that she could live really with half a bladder afterwards.
Thank you very much, Professor Bracker. We appreciate your comment. Professor Bracker has done a lot of work for young women, for women who have had congenital abnormalities of their reproductive system, that often they have more endometriosis, and we really appreciate your comment. I do like to let you know that we have a lot of questions, and because we have so many questions and there is a lot of interest, we will continue our discussion for half an hour more. We might not be able to answer all the questions, unfortunately, but I'd like to thank our fellows, Dr. Anupama Rambatla and also Dr. Janelle Jackman. They are online. They are also answering some of the questions. And I will try to combine some of these questions because there's a lot more left. I have only addressed less than half of the questions. So I would combine some of these questions together to see if we can answer them. And the next question is, and hopefully this question perhaps Dr. Farnejad could address it. Where are the origins of endometriomas and how do chocolate cysts form? I do want to let you know Dr. Farnejad developed a theory and he came up with an idea that was proven where endometriomas come from, chocolate cysts. Dr. Farnejad, go ahead and please address that. We appreciate it.
Briefly, before I mention about endometrioma, how they are formed. If you look in the pelvic cavity, the only area that we could see large endometriomas are on the ovary. So we looked in a large number of our patients and we classified the endometrioma to two types. We call them type 1, that usually are small cysts, and when you drain them, when you want to excise them, are very difficult to remove. And we call them type 1. And the original of these endometriomas are similar to endometriosis of the peritoneum, the bowel, the bladder is the same. The second one, which are the most common one, are involvement of this type 1 endometrioma or superficial endometriosis in the ovarian cortex or the pelvic sidewall, which attaches to the functional ovarian cyst mostly corpus luteum. So what happens is endometriosis is in the cortex, interferes with that function of that ovary, and would not allow that corpus luteum that's supposed to disappear by the end of the month. Assume the patient is not pregnant, and I assume the patient is not on any kind of hormonal suppressive therapy. And this corpus luteum is supposed to disappear by the end of the month, does not. So gradually that endometriosis on the ovarian cortex or when the ovary is attached to the pelvic sidewall penetrates to this ovary, and that corpus luteum become ductless cyst. And depends the age of that cyst, we classify that type 2 to type 1A, type 2A, B, C. That has helped us to manage our patients, not only during the surgery, also post-operatively. A lot of concerns of removal of the endometrioma is decreasing the ovarian function. And removing the endometrioma could be very bloody. Could cause fibrotic tissue, and when you pull the cyst wall out, could bleed, and then you have to use diathermy, cautery to stop the bleeding. So if you excise only that ring around the chocolate cyst, the rest of them easily will come out without damaging the ovary. Also, as I mentioned before, if the endometrioma is removed and you put the patient on suppressive therapy, that patient does not ovulate, I promise you, patient will not develop endometrioma. This has been our experience for past more than 30 years. And other people also have published that people that they are on suppressive therapy, endometrioma recurrences are low. Opposite way, if the patient gets stimulated and produces multiple cysts or multiple corpus luteum like IVF, these people are higher chance for forming endometrioma.
Thank you very much, Dr. Parnejad. Now, there are many questions regarding how to manage post-operatively after the surgery, how to manage the pain, and how to prevent endometriosis from coming back, and how everybody manages that. And as Lily mentioned it, that she says endometriosis often is associated with other problems. Patient might have other issues, like this patient, several patients actually have had questions that besides endometriosis, one of them has PCOS. The other patient, she says, besides endometriosis and PCOS, she has chronic fatigue syndrome. Another patient, she has thyroid disorder and endometriosis. So post-operatively, when this patient, they have pain, how do you manage them? Do you use Mirena IUD? What is the risk of recurrence of ovarian cyst? Professor Bose, how do you manage post-operatively these patients for their pain, and what do you advise them? Hello? Yes.
Hello?
Yes.
Well, first, it is important in order to prevent the endometrioma to come back. I think first it is very important how the procedure was done. Was it done by open procedure or laparoscopically? So when you do laparoscopy, you see better, you can treat better, and you can actually treat even small lesions on the surfaces of the ovary and prevent them of getting back to chocolate cyst. But if the surgery is done precisely, I think that oral contraceptive pills is an option. is an option because oral contraceptive pills are associated with reduced recurrence rate of dysmenorrhea, pelvic pain, and of course endometrioma. So I think that it's an option for these patients.
Thank you very much. I have a question for Professor Brucker. Actually, there are several questions. I combined them together. And these questions are the endometriosis. If we, after you have had surgery, how can we best manage it post-operatively to decrease the risk of having another surgery? Is having children, like having several children after the surgery, would it help you to have less endometriosis until you go to menopause? Probably having you have to have many children, depends how old you are to go to menopause. But or should you go on some kind of medication to avoid you having the risk of recurrence? How can we cut down the risk of recurrence of endometriosis?
Yes, as Dr. Bosev just said, what is very important is that the surgery is really done precisely, which means that you have to know if you have got removed most or all of the endometriosis lesions. Because after that, if you then put, for example, the patient on an oral contraceptive, you have the best chance that endometriosis does not come immediately back. So the most important thing is to look that you remove most of the lesion, or especially if you can, all the lesion, and not just coagulate them, but resect them really and remove them. And then it depends. Of course, we all want to have many children. This is a good thing. So during you're pregnant, you can be assured that normally endometriosis does not come back. But of course, if you are 20, in your mid-20, and if you wait until menopause and be pregnant all the time, not for everybody, this is a good option. But of course, if you are, let's say, 25-year-old, diagnosed with endometriosis, had a good and perfect surgery, and then you take oral contraception for, let's say, 3-4 years, normally you're really on a safe side. If you have a real severe endometriosis, you could also put your ovaries for about 3 months with no function. If you have, for example, an injection which helps to get 3 months the ovary no functioning, and then start again back. And we have good experience that then patients really get fertile and pregnant afterwards, because then the ovary has slept for a while, the endometrium had become quiet as well, and if you then start to get pregnant, this is a really good time frame, and normally patients get immediately pregnant afterwards.
Thank you, Professor Brucker. There are many questions that perhaps Professor Sinanejad can answer, and that the question is, a lot of patients have chocolate cysts, endometriomas, and they have no other symptoms. And many of these patients, they are trying to get pregnant. They want to know, they have no symptoms, they have only the endometriomas, and what is your experience? And the IVF physician, they say, no, it is okay, you don't need to have surgery, and endometrioma could be well. How do you feel and how do you approach these people? Could endometriosis be treated and respond? This is a patient exactly like what Marketa was mentioning it. There are many patients in the shoes of Marketa that they have endometriomas and endometriosis. Some of them don't even have pain.
Thank you. This is an excellent question, and it comes up very frequently. There are organizations, societies that they don't have a clear answer for it. Like if you read X-ray guideline versus ASRM guideline, they are all based on the statistics. So in my practice, when the patient comes to me, pretty much they have failed everything. So, and I'm a surgical practice, and I know what I can do for the surgery, for the patient. But for this individual, I think Marketa answered all the questions. If you want to be statistics, then you go by recommendation. Many people go and have IVF. A lot of them get pregnant. A lot of them don't get pregnant because endometrioma and endometriosis is proven to have a toxic effect on the ovary, on the endometrium. It could affect the ovarian response. It could affect the quality of egg. It could prevent from embryo formation, and it could affect implantation. All of these are the criteria that needs to be considered. Thank you.
Thank you. I appreciate it. Professor Brucker and Professor, do you have anything to add about endometriomas, endometriosis when they are asymptomatic on infertility patients?
Well, what we have learned is that on one hand side, endometriosis is something or could be something like a chronic disease. But what we also have learned is that if you have only minor lesions seen in the surgery, this could also affect your fertility. So you cannot combine that if you have only a few lesions, there could no effect in the fertility. And if you have a lot of lesions, this affects your fertility. So this is what we have really learned. So if you try to get pregnant via IVF, for example, and have been diagnosed with endometriosis and you have no success, it is worthwhile again do a laparoscopy and look, even if you have no symptoms, because there could be a few lesions, and if you resect them, your inflammation in your pelvis gets lower, and sometimes these patients really get pregnant via IVF or via natural cycle. So combining that if there are no symptoms, you have no endometriosis is false. You can have endometriosis without having major symptoms. And if you do not get pregnant, it is worth to do again a laparoscopy and look, and if you see lesions, remove them.
Thank you very much, Professor Brucker. Professor Bozeb, how do you address this question?
Well, I think that it is very important to know how the patient wants to conceive. By all means, if the patient wants to conceive naturally, I think the best way to address endometriosis is through laparoscopy and to treat endometriosis laparoscopically, because it increases the chances to get pregnant naturally. And I think that it is important to note that even there are small cysts, the endometriosis is invasive disease, and it goes gradually, and by laparoscopy you can restructure the anatomy and conceive naturally. I think that's the biggest advantage of laparoscopy. And the other thing is that with laparoscopy, as I said before, you see better, you treat better. That's the real advantage of laparoscopy for the surgeon and for the patient.
Thank you, Professor Bozeb. And how about you, Professor Farnejad? How do you approach them?
I agree 100% what it was said, that in our opinion, any infertility patient that has whatever cause of infertility has been ruled out has to have laparoscopy, and any endometriosis has to be resected. As Professor Barker said, the pathophysiology is very simple. The endometriosis is an inflammatory process. And when you resect the endometriosis, it decreases the inflammation. That is the reason that most of these patients to get pregnant immediately. The endometrioma is part of the whole scenario. I'd hardly ever seen in my practice that patient had purely endometrioma. Even 2 centimeters, 3 centimeters, this endometrioma are not by themselves. It's endometriosis somewhere else. And if it is resected, the patient will get better, pregnant spontaneously or with IVF, as it was published by Cameron several years ago. And I see in our practice frequently that patient had failed IVF and has come for surgery. Interestingly, some of these patients, when they come back for 6 weeks checkup, even are pregnant on their own. And I have seen it numerous times.
Thank you very much, Professor Farnijad. The issue is, in a lot of the question that came across is in respect to endometriomas, chocolate cysts, their management, how to be done in respect to infertility patient, in respect to pain patient. Every single patient has to be individualized. We tried to answer these questions in general, but each of you have to see somebody, a physician who is known, he knows how to manage endometriosis. In case of endometriomas, and also endometriosis, and women who try to get pregnant and have no other symptoms except small or sometimes larger endometriomas, it is not alone, as Dr. Parnijad said. Endometriosis, if it is treated thoroughly, especially in younger women, and if the husband's sperm is normal, the chance of pregnancy is excellent. As in the younger age group, according to our own papers and our own data that you can scan it, it is on this barcode on my slide, the pregnancy rate on the younger patient that the husband's sperm is normal is actually better than IVF in our hands, in our way, for sure. And if the woman is older and she has failed IVF and she is no reason infertility, she still could have endometriosis and she could still get treated, and her chance of getting pregnant by repeat IVF, in our experience, is much, much better than going ahead and just keep doing IVF. So that is our experience. And to diagnose endometriosis, there are some tests coming up, like receptiva test, endometrial receptiva test. These are other tests are coming up. Also, worldwide EndoMarch has developed an app that it is free. You can do that test. The other tests are you have to pay some money, but this one is free. You can be diagnosed, and your endometriosis, if treated properly, you could have a better chance of getting pregnant. So, in summary, the care of endometrioma should be individualized, and you should see proper physician for your management. For endometriosis of the bladder and ureter and even the bowel, an expert could manage and help you. There are guidelines, there are published papers, and I'd like to thank enormously Professor Bose, Professor Brucker, and Miss Lily and Cooper and her mom Karen, and Marketa, Stella and Ryan, and also all of you, the listeners and also participants around the world, for the expertise, for your interest, and we look forward to seeing you all next month, and send us your question. As I mentioned, next month would be about adenomyosis endometriosis and myoma of the uterus and their relationship, send all of your questions and I would be happy to answer them. Meanwhile, you all stay safe and we say goodbye to all of you. Thank you very much again.
Hi, this is Dr. Maurice Chung. I am a urogynecologist and chronic pelvic pain subspecialist. And thank you for Dr. Najat inviting me to be here to discuss with you about the chronic pelvic pain, endometriosis, or any other conditions such as interstitial cystitis. So let me start out with sharing the screen with you. We're going to talk about the chronic pelvic pain. And I have no financial disclosure, and thank you for the opportunity to share my passions. I am from Hong Kong. These are my families. And currently, I'm working at West Virginia, Wheeling, and I call that the mountain home. And this is my work and my mission is to take care of patients with pelvic pain, including endometriosis, interstitial cystitis, epineuralgias, or others. I mean, ironically, not too many gynecologists or urologists or general surgeons like to take care of pelvic pain patients because they are a very, very difficult group. And pelvic pain definition is more than 3 months duration, is at the lower anatomical pelvis, including the buttock, the lumbosacral, and the back. So endometriosis basically fit into that category. Those patients have poor quality of lives, and they have so much pain that make them inability to work and concentrating. Of course, that they all pretty much have painful sex. It is a very significant and common disorder in women, and over 40% of laparoscopy and 18% of hysterectomy were performed for the pelvic pain conditions. And of course, majority of them have endometriosis. So that led to the diagnosis of laparoscopy, and I have to thank Dr. Najat's his vision back in 1980s, and I learned his technique of using video laseroscopy. These are some of the endometriosis in the urosacral ligament area, and it would be a mistake to just burn them instead of supposed to be completely remove them. However, when you remove them, that doesn't mean that the pain is gone. Endometriosis can be gone, but not necessarily the pain. And the stage 1-2 endometriosis appears to be less effective. Stage 4 endometriosis appears to respond very well with the surgical excisions. The surgery result at best is 50% reduction of pain for 5 years. This is pretty much like in 1997. That's all been disclosed with these studies by Dr. Winkle. And using medical management doesn't necessarily relieve the symptom, and the symptom return in about 50%. It's a high failure rate. And now we have some oral medication. However, this medication, when you look at those numbers, the placebo effect is 20%. So at a high dose, only half of the patient would reduce painful period, and less than half of the patient would have relief in dyspareunia. That is related to endometriosis. That's very expensive. So how many surgeons here have the experience of the patients remained in pain and continue to have painful intercourse after endometriosis surgery? And how many patients told us, surgeon, that they continue to have pelvic pain worse after surgery? And there are many surgeons have dealt with endometriosis patient complain about pelvic pain, abdominal pain, have no obvious diagnosis in surgical finding. So obviously there are some pelvic pain condition that is not related to endometriosis. However, I do believe that pelvic pain is neuropathology, and every pain generator in the pelvis can lead to the nerve that get agitated and causing prolonged chronic pelvic pain. And in 2003, Dr. Najat, Cameron Najat was with me in San Antonio. I get a chance to present this topic at 79 patients with clinical diagnosis of residual ovarian or ovarian remnant syndrome. And they were proved to have cystoscopy with interstitial cystitis. So why do we have residual ovarian syndrome? Is some of these patients have hysterectomy for pain or for endometriosis, and they continue to have persistent pain. And maybe the original pain had nothing to do with endometriosis. How about adhesions? And there were so many studies, there are like 6 of them here. After adhesion, lysis of adhesions, after 6 months, the pain returned to the original level. So does adhesion cause pain? Maybe not. All these patients, 75% of them have interstitial cystitis. So back in 2004 and 2009, I finally published these 2 papers for those patients who have hysterectomy for pelvic pain or for a variety of reasons, including endometriosis. 79% have interstitial cystitis. So we cannot just focus on endometriosis. It's the entire pelvis. It's a neural upregulation, pelvic neuropathy. After all, it's all the nerves that connected with all the pelvic organs. It's a complex network. And many times we have pain on the abdomen. It could be the referred pain from the pelvis, or the abdominal pain could refer to the pelvis. And these are some of the locations where patients have pain in the pelvis. So, wow, do we know anything about pelvic pain? It's just so confusing. And there are peripheral neuropathy. You look at all these nerves that can give you the pain, and patients that have endometriosis may stir up the nerve, make the pelvic area more painful. That might be the reason after you remove all the endometriosis, the pain's still there or come back. So you look at all the pelvic pain, it's like multiple conditions. And if one area burn on fire, that's the fire starter. And every other area started to burn harder and hotter. So how could you find out where the pain's from? So it's very important to desensitize the pelvis and then do the surgery. It's like the Christmas tree. The base of the Christmas tree with multiple strain of light that was not working. And you don't even know which light bulbs can fix the strain. So sometimes you think it's endometriosis, could be the green, but you put it back in, it didn't work. It could be interstitial cystitis, and you put the yellow in it, it didn't work. Or the pudendal nerve, it's the blue one, so on and so forth. But when you put them all together, get a new bulbs and put them all in, and then the tree lights lit up. So it is not just one condition. It could be multiple. There was a reason why surgery failed. It's not the endometriosis not removed, it's the nerve continue to cause the pain. I've been working for a long time for treating patients with interstitial cystitis. Like 20 years ago, I really believe that is interstitial cystitis and endometriosis. They are like the twin sisters. But when we look further, that the pelvic pain of the bladder is only 30% of all the female pelvic pain, where the reproductive source is 20%, GI or muscles. So endometriosis or pain in the pelvis from endometriosis probably only occupy 20% of all the patients with pelvic pain. Let's talk about interstitial cystitis. It's a lining of the bladder urothelium. It's kind of getting irritated and missing. So the chemical in the bladder, which is the urine, can be very irritative. So high potassium or high hydrogen ion can irritate the urothelium and irritate those nerves and causing pain. So what we eat can be an issue for a patient with painful bladder syndrome, IC. So I published these two papers. One is endometriosis with interstitial cystitis, and I found that the correlation is just too high. So I did the second publication and turned out to be correct. And in these two studies, I found the coexisting of the two conditions. It is high. So even though we take care of endometriosis, we still have to consider bladder is the source of pain. So we need to find out whether the bladder is the cause of the pain prior to any major surgical intervention. So early identification of interstitial cystitis may avoid unnecessary hysterectomy. So treating IC require some medications, watch your diet, intravesical therapy, hydrodistension. Sometimes we use the Botox, and there are some other modality. And I published this abstract in 2005, suggested that patient with IC in pelvic pain, when you instill the bladder with this anesthetic solution, they have over 50% improvement in 85% of the patients. This is the finding on hydrodistension. You can see those area with the bleeding and with mucosal cracks. So let's talk about other conditions that can cause pelvic pain. This is the pudendal nerve. Pudendal nerve is the nerve that regulates the entire pelvic floor. And pudendal nerve is from the sacrum S2, 3, and 4, and believed to be the two ligaments where the pudendal nerve travel through, squeeze the nerve and causing the pain. So what would do that? Childbirth, injury, cycling, many other conditions that led to the injury of the pelvic floor ligament can indeed cause pudendal neuralgia. The pain in the pelvis is aggravated by sitting, reduced by standing. While lying down, they are better. And when I examine patient, when I touch the sacrospinous ligament, and they're very tender. And the symptom including painful sex, decreasing sex drive, bladder symptom, bowel symptom, and the menstrual symptom. So in 2009, I have this abstract published in the JSLS, and in pelvic pain patients, I found endometriosis, I found the IC, and I also find that they have pudendal neuralgia in about 80% correlations. So the treatment is pudendal block. And we can do it through the buttock or through the vagina. And I put some contrast. You can see that the radial shadow is the sacrospinous ligament, which is the top of the ligament is the coccygeus muscles. So the injection was in the right place. Neuromodulation also helped take care of pudendal neuralgia and painful bladder syndrome in the urgency and frequency. We put an electrode through the sacrum and regulate the bladder functions, and it helps to desensitize those bladder nerves. So in the earlier study, I have found that 80% of those patients have at least 50% improvement in the symptom. The other part of the pelvis that can cause painful sex in endometriosis patient, maybe endometriosis that started the pain, or maybe patient also have some injury in the pelvic muscles, so endometriosis pain actually flare up the muscle pain. So then you're gonna ask which comes first. Toxic is also another area that can cause pelvic pain. And endometriosis patients, sometimes they do have crampy period, painful sex. However, the painful sex may not be just due to endometriosis, maybe due to coccydynia or the muscle and nerve pain in the pelvis. First of all, we have to learn how to do a proper examination, not the regular gynecological examination. We can only examine patient with one single digits, because the more finger insert into the pelvis when patient have so much pain, and you're not going to find the right answer. In the last 30 years, I studied a lot on patient with IC pelvic pain and come up with sequential desensitization. And I just finished up the paper and will be published sometime in the future. And this is what the algorithm called for. When patients have pelvic pain, we went through evaluating the bladder, then followed by the pudendal nerve. And then we come up with an algorithm, and 85% of those patients would have more than 50% improvement. Some of those pains gone. Now, these are the patients include endometriosis patient with previous surgery, and that is about 300 of them. So after all, we know that patients with pelvic pain have some issue with the brain chemistry. And we found that patient with endometriosis with pain versus endometriosis without pain. And there's an area in the brain have decreased gray matter. So in the conclusion, I just want to share with you, patient with endometriosis, especially with multiple previous laparoscopy surgery, should probably be evaluated for interstitial cystitis, pudendal neuralgia, and myofascial pain first. And my algorithm could avoid most of the surgery. However, when you talk about surgery, you have to excise all the endometriosis in the pelvis. If you cannot do that, please just take a lot of pictures and send the patient to the expert surgeon to avoid multiple surgeries for the patients. So I have to conclude my presentation with the eye does not see what the mind does not recognize. What the eyes does not see and the mind doesn't know, it doesn't exist. So I see, you see, you don't see the I see. What you see may not be what it is. It may be. Well, back in those days, we just see endometriosis is the tip of the iceberg. And after 20 years of teaching, then doctor knows interstitial cystitis. However, there's a lot more involved in it, including pudendal neuralgia, irritable bowel, vulvodynia, and the nerves. So it's very important that we find out what are the conditions that cause the pain and follow the algorithm. It would help a lot. And then eventually patient needs surgery, but you should do surgery when the patient has the least pain so you do not flare up the underlying pain syndrome. And this is something new. So I have to use this quote. The illiterate of the 21st century will not be those who cannot read and write, but those who cannot learn, unlearn, and relearn. Thank you very much for listening. I hope you all have a good meeting, and thank you, Dr. Cameron Najat's invitation. I would like to be there one of these days. Thank you. Well, thank you very much. And goodbye.
Good afternoon. My name is Gerard Paulian, and I am a worldwide EndoMarch headquarters volunteer. And today we have the EndoMarch representative from Team Malaysia, Sarita Morgan, joining us today. Thank you so much for your time, Sarita. I know it is actually quite late in Malaysia. How are you doing?
Thank you so much, Gerard. It's been a pleasure being invited for this interview, and I think it's important to address this. And I'm glad that the World EndoMarch is making a big step in even communicating with girls all over the world.
Of course, of course. Well, the pleasure is truly all mine. I'm happy to announce that Team Malaysia has been making efforts to increase advocacy and involvement during the fight against endometriosis for about 10 years. They got established in 2013. So now I was wondering if you could give us a rundown as to how Team Malaysia's efforts have furthered endometriosis awareness in your area. Are there any specific events that have been particularly successful with people?
Okay. Well, Gerard, to be honest with you, awareness is still low, but I'm glad that we have started this way back in 2014, 2013. And it's still a taboo to talk about period pain. And I think as our association is trying to do, we're trying to make a drastic stand against misinformation about endometriosis. We're trying to change people's perception about this condition. And I think our harshest critic is, well, basically other women, they are our harshest critic, because the perception that period pain is something that we should not talk about, we're trying to get rid of that. So our association has been trying our very level best to educate the public as well as healthcare professionals, because sometimes we do see doctors being dismissive, so we're trying to address that as well. Now, what's happening in school, we are actually doing something, we're making some steps, we're trying to educate young girls in school. Now, the girls in school in Malaysia, they're mainly taught about menstrual hygiene, and not many of them are taught about menstrual pain, so that's what we're trying to do. We're trying to start somewhere, and we're getting that done by dealing with teachers first, talking to teachers about period pain, educating them so that they are the first individual to identify young girls who have period pain. So that's the monumental step that we have taken. We have conducted an online talk with teachers last year. We have also done some talks in schools and to educate young girls in schools as well as girls in the university. So that's where we wanted to start, because as you all know, sometimes these girls start having their pain in schools and in universities. And that is why you have the 7-year diagnostic delay, and it's not being addressed. And of course, the other thing that we try to change is the perception that it's just period pain. So we're trying to do that by educating the public. That's the step that we're trying to take, slowly.
Well, it's very difficult to educate the public overall when people are very unaware of the condition. They don't even consider endometriosis a possibility for their pain. So the fact that you're trying to educate the younger population is very, very important, because when they have grandkids and when they have children, then they can educate their children and grandchildren, and from there, hopefully, everything will get much better. Sadly, overall, 10 years is such a small amount of time to make a substantial effort. But every single effort is chipping away at the grindstone, and eventually, it will become very known and knowledgeable in Malaysia.
Yes. So
go
ahead.
Yeah, you go ahead.
You go ahead, Gerard.
I wanted to actually clarify that 7 to 10 year diagnosis delay in your area. Have there been any studies showing either an increase or decrease in that delay over your 10 years?
I think there's a slight decrease, Gerard. There is, it has now reduced to, we have done a survey, it has now reduced to about 4 to 5 years, you know. But I think it's both sides of the coin, you know, because we are not educating people enough, you know, because Malaysia is a country where we have a lot of states, different states, many different states, and a lot of these education is in the urban areas, you know. We're not reaching out to the rural areas, so that's where we need to play our part as well. But due to lack of funding, so we are doing it step by step. But like I said, it's not an easy journey. We hope that this is a continuous process, and we're glad that we are starting it here now with this association. And hopefully in the next generation, we can actually see awareness on this condition, a lot more awareness. And we're hoping to change the perception of young girls. You know, a lot of them are only seeing a gynecologist when they have fertility issues. They're not seeing a gynecologist when they have pain, simply because people around them are telling them that pain is normal for females, and pain is synonymous to women, you know, or girls, you know. So that's the change that we want to make. We want to change that perception. We want them to get this addressed early on, and that must come from the community, because educating girls is just not enough. We have to educate the people around these girls, like their family members, their spouses. We have to do that, and it's a monumental task. It's not an easy task, but I think it can be done if we really push through. And I'm glad that we have a committed group of people. Our association, we have a group of people that's working tirelessly to help make the changes that we need, you know. So that's the baby steps we're doing, you know. So I'm glad that there are some changes. We see a slight reduced in the diagnostic delay. So that's an interesting development. So hopefully in future we can see a lot more changes in terms of the diagnostic delay.
It's amazing to hear that the diagnostic delay has gone down throughout your 10 years, because even though it can be a very, very small decrease, that in itself is a huge accomplishment.
Yes.
Especially since you've talked about that, talking about gynecologic issues is kind of more of a more restricted in your area. Would you say that talking about these issues is kind of more of a cultural taboo in Malaysia? Why isn't it talked about as much as it is in other countries, for example?
It's still considered a cultural taboo, Gerard, because well, the perception is, you know, sometimes when you look at religion, period is considered unclean. You know, in some religion, we are not allowed to go to places of worship. So there's this cultural taboo that's going on. And I think talking about it openly can be uncomfortable, especially if you have people who still think that, oh, this is something private and it should not be shared, you know. So again, it's not an easy thing to do. When we speak to young girls around, you know, we tell them to speak about this condition, and some of them are not very open about it because they feel like it's something embarrassing to talk about, you know, especially to the public. So what we did, you know, our association did a very big thing this year. We actually launched our video of 4 Malaysian girls talking about their period pain. And this is a breakthrough because this video is it's a combination of my endosis with the Obstetrical and Gynecological Society of Malaysia. So it's a collaboration effort. We came up with a video, we launched it in March, and we hope to actually disseminate this video, especially in hospital waiting rooms. So I think this is the step that we're trying to take to educate people about period and of course about endometriosis, and to address the unmet needs of women with endometriosis. That's what we are trying to do.
Of course, that's a very big goal you have there, and I know you guys can definitely accomplish it. And I can only imagine somebody going through so much pain during their periods and so much pain on their daily lives and not being able to talk about it. And once they see that video that you've created, I know that there's a lot of people out there that have resonated with that content and finally felt like they that somebody out there understands what the pain feels like and that it exists. So I know you've made a lot of people feel better with that video. So congratulations on your impact.
Thank you so much. And Gerard, I still have to tell you this, that we're also doing a lot of research on the community, you know. So for me, myself, I'm doing my PhD on endometriosis. I'm looking at doctor-patient interaction, looking at some of the challenges doctors face when they speak to patients, especially in terms of addressing the cultural taboo, you know. So it's not only I'm not the only one doing PhD on endometriosis. There's so many research going on here, you know. So we're actually excited about the findings. We're actually excited about publishing it. You know, this can make the change that we need, you know, here in Malaysia.
Yeah, not only does the general public need to be educated, but doctors too need to be educated. So I'm very glad that people like you and others are really furthering that doctor-patient relationship, making sure patients aren't so easily brushed off by their doctors. That's an amazing aspect of our mission to address. I also wanted to ask, as the years have gone by, if it's become easier to find endometriosis specialists in your area. Are there even endometriosis specialists in the area, or do they cover multiple fields, for example?
Okay, we do have a specialist in our area as well, you know, but I think we still need more, you know. We don't have enough, you know, so we are worried about that, you know, because sometimes patients tend to go to healthcare professionals that are not skillful enough, and that can be a problematic condition, you know, problematic issue. Problems will arise from there, you know, if they're going to individuals that are not skillful enough. You know, that's what we need here. Again, we're also trying to work with healthcare professional society groups, association, and they're doing their part as well to educate general practitioners and gynecologists. And hopefully with this combined effort, you know, we could actually get people who are truly skillful in dealing with this condition. And of course, in addressing patients' needs.
Of course. Well, Sarita, I really want to commend you for your admirable contributions and impact towards endometriosis awareness. I know everybody in Malaysia and all over the globe really appreciates your monumental impacts that you've done to further awareness. Are there any last words you would like to add on behalf of Team Malaysia?
Okay, Gerard, I wanted to say that we wouldn't be here without the support of World EndoMarch, you know, because I've started this group in 2013 because of World EndoMarch, you know. Back then there was this initiative to push people from different countries to speak about this openly in their country. And I think I have you guys to thank, because of World EndoMarch, we are here now. My endosis existed. And I think looking at your work abroad, it's truly admirable, you know. Walking on the streets and speaking about this openly, it's something to look up, you know. I really hope that we could actually do this here in Malaysia. We hope that it wouldn't be a point where we're uncomfortable, you know. So I'm glad that you guys actually initiated us to do this, you know. So I'm truly happy to be part of this, you know, in a big way.
Well, everybody at Worldwide EndoMarch, we would be nothing without the continuous efforts of all of our teams all over the globe. So thank you so much, Sarita, for your time. It's amazing to hear the story of Team Team Malaysia and the big impacts that you've accomplished and that are going to come in the future.
And thank you to Dr. Kamran Nazhat, and team, and all the people there in US who have been totally supportive of our cause to create awareness in this country, and everyone else. Thank you so much.
It's my ultimate pleasure to talk to you, Sarita. Thank you so much. I hope you have a great day.
Yes, thank you. Thank you for inviting me.
Hi, my name is Roya Tagavi, and I'm a worldwide EndoMarch headquarters volunteer. I'm here today with the EndoMarch representative of Malaysia, G. Once again, it's very nice to meet you, and thank you for taking the time to answer some questions today. To start off, I wanted to ask, how did you become involved with EndoMarch?
Well, it was by accident actually, because the president of my endosis, Surita, is actually my working colleague. So one day I just came across her poster design, and I was like, okay, this is not. I mean, I didn't really. It was not appealing and it wasn't good. So I was like, why not I just help you do it? I can, since I teach graphic design and advertising, so I kind of volunteered my services to her, and since then I've been helping out with my endosis. Yeah, it's been years actually since they established. Yeah.
Yeah, I'm sure your skills in graphic design has contributed immensely to efforts to raise awareness. But before we get into that, I just wanted to ask, in your opinion, is it easy to find an endometriosis specialist in your area?
In our country, there are a few, but I mean, mainly we have many gynecologists, right? But specifically for endo, we have only quite a handful actually. Yeah, because not all gynecologists are well aware or into endometriosis, So, however, we have a very good support group here where we can lead or guide patients or anyone who wants to do a diagnosis to the right gynecologist who specializes in endo. Yeah.
Could you tell me more about this support group?
This support group is actually a Facebook group.
Okay.
Yeah. So we started from a Facebook group, and then we registered it to be a legal NGO in Malaysia. Yeah, there are a few endometriosis support groups, 2 or 3 in Malaysia. However, we are the only one, if not mistaken, who is registered legally. Yeah. So we started very small from the workplace actually, and we grew bigger
Right.
and stronger, and we have seen tremendous growth and amazing work that we have done. We have came a long way, and since I can see a lot of impact that he has done, not only for our committee but also for our country as well.
Well, it's amazing to hear that you guys are expanding. That's the goal, right? And I'm sure you'll only be expanding from here. So along the same lines, how have your other efforts, any projects, increased or furthered endometriosis awareness in your area?
Okay, lately for the past few years, I think one of the biggest impact that we have is that we have be able to get medical professionals to work with us in our efforts, to create more awareness and to basically to explain to the public and also patients on this as well. So I think that is one of the strongest points that we have, because public normally, people they normally tend to believe or trust a medical professional better, compared to us when we are we are an NGO, but we do not have the medical background or knowledge, to explain further or answer the queries.
Right. Absolutely. I agree with you. You mentioned earlier that you do some work in graphic design.
All right.
So how do you exactly use that and those skills to, I guess, do these create these endometriosis projects and capture the attention of people?
Okay. Since I started, I actually helped this NGO with all their collateral materials, their posters and whatnot. But lately, what I've been doing is that since awareness is very low. One of the important things that I find that if you want to really make an impact is to make people understand what is endometriosis. Like myself, I do not have endometriosis, and I did not know what is endometriosis until I started working in this NGO. So for the past few years, actually past 2-3 years actually, since I am actually a lecturer as well in a private university, so I make students project on endometriosis as well. For example, last year I teach software design in Adobe, so I made their projects where they have to design poster designs to create awareness on endometriosis. So one thing is I'm able to get not only girls to know what is endometriosis, but also the boys in the class as well. So I think that is really amazing because before they do the poster design, they have to go and do research. They need to understand, learn about it. So I think it's a win-win situation. For me, I'm able to get good designs from them as well, which I am able to use it for our association. And I'm also able to create awareness, teach the young generation what is endometriosis.
Well, that's great that you are introducing this into your classroom. That's such a great platform to use, I guess, because education is so important.
It is.
Yeah. So do you share these graphics on social media or various websites?
Yes. After the project was over for this year, actually during the March, we have our endometriosis month. So what I did was I shared one poster a day. So, it's like, since I had about 30 designs, so it's also because to make the month to be much more livelier, So every month I shared a poster design that gave a really good impact for the community and also the Facebook support group as well. Because I could see from the likes as well and the comments as well. And it was also very good because the students, when they saw their work is being shared, and it's being seen by the public, it gave them such a motivation, because right now, we are in the 21st century and real world learning is very important. So by giving them a real event or a situation, it gives learning is not only done in class, but they are able to use whatever they have done in class for outside, for the public, for the society as well.
Yeah, to give back to the community.
Yes, correct, exactly.
So for others looking to share information about endometriosis like yourself, what graphic design tips, I guess, would you give them to help gain an audience, to capture people's attention and raise awareness for endometriosis?
Graphic design, visual communication is very, very important. Right now, visuals attract people compared to words. So what I always tell students is try to make your work not so complicated. Don't use bombastic words, terms, medical conditions and whatnot. Make it simple. Infographics are very good. People want to see, to get the rough idea, basic idea, what is endometriosis, what are the symptoms and whatnot. So we can do designs in stages. You can break it down into categories and just make it visually appealing, attractive, use appropriate colors as well. So color psychology is very, very important as well, and most importantly, I believe that visuals, they attract us first compared to text. So if we get the correct visual, a good engaging visual, we'll be able to make them to read the content of the material that we share with people.
Yeah, I guess one of the first steps is how do we get people engaged, and
correct.
graphics, that's so important.
And
yes, sometimes people may overlook it, but it shouldn't be.
Yes, correct.
So I just wanted to end off with a question, and that's, what changes do you think are still necessary in your area specifically in to aid in furthering public knowledge of endometriosis?
Because Malaysia, we are in an Asian country, so we have still a lot of taboos around this topic, endometriosis. especially period pain. I have many students who always, oh, Miss, I can't come to class because I have period pain. And, so what I can do as an educator is I will tell the class, whether there are boys or girls in class, I tell them generally about endometriosis. It's actually a way for me to educate them. I try to make them, not be shy about the topic, try to make them understand, try to break the taboo. So, and also the mentality is very, very important. We need to break out from the mentality that this is only got to do with women, or if you have a period pain, bad period pain, menstrual pain, you just take Panadols. We have now medications a lot in the pharmacies, in the marts over here as well. You just pop it up in. So we need to educate them that period pain is not normal. It could be normal, but it could not be normal as well. So, and also they need to seek medical professionals. Do not seek advice just from online, Google, support groups, but also be brave enough to go and seek medical advice, knowledge, and think positively that this endometriosis, there is always a solution for it. And the other thing is that we need to get also the male to be involved in this, whether it's just families, father, brother, boyfriend, husband, they need to understand it and be more empathic. Yeah. So I think the key word here is also empathy, because empathy is very important. It's lacking in our community nowadays, So they need to put themselves in the shoes and understand, even though it's like myself as a lecturer, I understand when my student has period pain. I try to understand, I be empathic, But being empathic, understanding, I also tend to give support, advice, and also try to guide them what they should do. Oh, you have period pain, is it very bad? Maybe you should not just take pop-in pills, you can go and see a doctor, see what is the cause of it? Is it endometriosis, or is it normal period pain? So yeah, so there's some of the things which I think is very important. And I believe that when I educate my students, or I tell my family and friends about endometriosis and about this, they are able to share it to others as well. It's like a domino effect, So even by just sharing about endometriosis, the word and what it is, it will trigger people to go and find out about it. And it will, it will carry on. So small changes will make a big impact as well.
Right.
Yeah.
I'm glad you mentioned that endometriosis is not just an individual disease. It affects so many aspects of life.
Correct.
So,
Yeah.
Getting males involved, not just females, is really important.
Yeah, because the pain is, of course, is endured by just individual. Only women, those who have the pain. But when we tell the people, they don't really understand it. So bring your family, bring your your partner, husband to the doctor's checkup as well. Listen, so they are able to listen to the doctor what they say as well. So it's not some people are making it in your mind. You can't take your pain threshold is very low. So try to get as many family, friends be involved, so they understand better and they know that this is not normal.
Yeah, and also getting rid of the taboos, like you said.
Yes.
Reversing the common notion about periods is really important. So I'm glad you mentioned that.
Yeah, I'm also very happy that because in our association, in our committee members for this NGO, we have a few males as well.
Oh, great. Yeah.
Yeah.
That's really good to hear.
Yeah, so and they have been very supporting since day one. And so it's again when public see that, oh, this association does not only involve women, they also kind of have some kind of a comforting feeling as well. Oh, there are men in the association, and we have also had events where we have for men alone to give a global guide talk, to give a talk to share their experience and knowledge. So it kind of it can also reach a different target audience, which is the male. Yeah, so we don't only focus on female or patients, but also young generation students, male as well. Yeah, so we try to do a few ways, to reach out to the community better. Yeah.
As a female, that makes me happy to hear. I can't wait to hear what Team Malaysia continues to accomplish in the future, and your efforts in raising awareness around such an important issue. Yeah. And I just wanted to say that before we end, are there any last words you'd like to share?
Yeah, I really say that I mean, being in this association, whether by chance or by I'm really grateful and thankful. So because I also have period pain. When I was younger, the period pain was painful. Now it's not so much, but I understand better, and I'm glad that I'm able to give back my knowledge and skills, not only in the university, but also to the public and society as well. It's my way of giving back to the community. Yeah, because we always say, oh, we always go for monetary donations and whatnot. We can also contribute to society and NGOs like this with the knowledge and skills that we have. Any small support that we can get from the public, even if it is by sharing a poster design, sharing word of mouth, anything, it helps a lot. Yeah, so I'm really thankful that I'm here and I'm able to help this association grow. And yeah, I hope that I have seen a very good a lot of changes and impact it's done to our endometriosis community in Malaysia, and also, like I said, outside the patients, reaching out to doctors, family members, students, and also schools as well. Yeah, we are reaching out to schools as well to reach the younger than used to. So I believe that we have a lot more work to be done, but all these makes us more motivated and excited at the same time. Yeah, because as an Indian, as myself, I believe in karma. What goes around comes around as well. So yeah, I'm really glad that I'm able to help out in my endosis and give back to the community. Yeah,
absolutely. I'm glad you mentioned that. Efforts and contributions, big or small, can make such a difference, and I absolutely agree with that. Thank you again, G, for your time. I hope you have a great rest of your day.
Thank you very much. Hope you have a good day as well. Thank you.
Thank you. Bye.
So, can you please introduce yourself and tell us about your story? How did you get involved with Worldwide EndoMarch? And if you like anything, whatever you want to add, you can add.
We have been established in Malaysia since year 2014. So since then, I'm the secretary, and as you know, the role of secretary is just not only writing minutes of meeting, but also organizing webinars, seminars, events. The main aim of our organization is basically to create awareness, especially as you can see, there's so much of lack of awareness, and the lackadaisical attitude of people about what endometriosis is all about. Now, I'm not a patient of endometriosis, but I am a patient of PCOS. I have PCOS for many years, and I've been through several surgeries to remove the cyst and the fibroids, etc. So I can empathize women with endometriosis. So that's the reason why I became a part of this organization. So she gathered some of us, we were all colleagues, and she gathered some of us and said, oh, there is so much of lacking of this knowledge of what endometriosis is all about in Malaysia. So we said, okay, let's march forward and create an awareness among in Malaysia. And so that's how we started. We started very small. I remember we had first meeting in Starbucks cafe, and then we moved on, recruiting people, and then we tried to create more awareness, and then women came forward with their very sad stories about what they go through with their lifestyle and what they go through with having endometriosis, and how people don't understand them. Even doctors don't pay much attention because it's a women issue, and it's just given a side limelight. It's not even a limelight, it's just like kept aside that, oh, it's a women issue. So so they were very depressed, a lot of anxiety in them. So then when we also created this Facebook, so that's where from the organization, after knowing the stories of all these women going through, then we approached ministry. We did collaboration with some of the ministries, some of different organizations in Malaysia, for a good example, like the employers, different employers in Malaysia as well. to educate them about, we need to have that relationship between what people think and what these women face, what people, what the perception of what the society has on women who face endometriosis. And honestly, based on experience, what I hear and what I see, it's like, no one cares. No one cares about your pain, or just because, they stigmatize us, they make us feel like, oh, you're a weak gender, you are a weak gender. So you go through childbirth. Good example, you go through childbirth. So that's a pain that you endured before. So
And
period
it's
pain
actually a
is,
pressure.
yes, it's a pressure. So period pain is something that you should endure. It's like it's how bad can it be?
Yeah,
So
you have to you start to ask yourself that am I exaggerating my pain, or do
yes,
I really have that pain? Yeah.
yeah. And then they, like I said, they label us, they stigmatize us, they put us as like a weak gender, and because of this ideologies that our society has on women, we end up feeling that, oh yeah, I'm weak, or I can't perform because of this disease I have. Or maybe it's just that something that I have to go through it and nobody understands me, so I have this anxiety attack. A good example, spouse don't understand you, your own mom that might not understand you, your in-laws might not understand you. Like in the Asian community, we are very how would I say, we are very close knitted. So we have in influence of parents, we have influence of in-laws, we have influence of peers, and we have lots of influence.
Yeah.
So all this is like, and even employers, they might not understand, like, okay, it's just a period pain, so why are you over exaggerating it, why are you dramatizing it? It's like you're just doing the drama, that kind of thing. So labeling happens. So I've seen, as a secretary, I've seen a lot, even on Facebook, and currently I'm also doing my PhD research on support system, on how Malaysian women with through online platforms such as Facebook or Instagram. So I'm really focusing on Facebook. So I'm looking at 2 different Facebook in Malaysia and how these women are actually getting support, different types of support. They have empathy, they are, of course, emotional support, then they have tangible support, they have various different types of support. So I'm looking at the types of support. So I'm still collecting my data, so I have no idea like what many, there are different types of support. What kind of support nation?
In your opinion, like how has endometriosis awareness like changed in the Malaysia, and what change do you think are still necessary in Malaysia? Or is it easy to find an endometriosis specialist in Malaysia? Or like, do you know about someone that has ever had to change the country to like reach out to endometriosis specialists or something like that? Can you please tell about us?
Okay. In the Malaysian scenario, looking back at your first area of question, I would say that the awareness is lacking. There's definitely lack of awareness, number one. And what needs to be changed is how we perceive what endometriosis is all about. So this is not about only patient, but it's also like how doctors are perceiving what endometriosis is all about. It's not just normal period pain. They prescribe us Panadols or Ponstan or, those kind of medication, painkillers, and say, okay, you take these painkillers and your pain will be lessened, and okay, you continue working or continue doing your tasks. But that's not the situation. So number one, I feel that we need to have awareness. Number two, we need to also educate the doctors, not in terms of what endometriosis is all about, but what the patients are going through. There's no empathy at all. That's what I feel in the Malaysian context. They cannot empathize, neither they sympathize. They just treat you like another guinea pig, and they just try all kinds of medication on you and see, okay, let's see what happens. They prescribe jabs and medication, and we don't know about the side effects. Some doctors don't even tell us about the side effect. And I know some of the medication side effect is so severe that it affects your bone density and etc. And these women actually cry about how their side effect is affecting their life, their lifestyle, their relationship, their partner, their family, etc. So that's one, we need to educate. Number two, I also feel we need to educate the men in the society. It can be the spouse, can be your brother for the matter, or it can be your boyfriend for the matter, or cousin, whoever, the men, that it's not period pain. It's not period pain. It's beyond period pain, and it's totally different from the pain that childbirth, and you can't compare. It shouldn't compare. So why we shouldn't be talking to men? Because men are not educated and they don't care because they just put us aside. It's a women problem, but it's not a women problem, because if you are talking about reproductive issue, then men are also involved in it.
Yeah.
So that's what I feel like. In the Malaysian context, educating the men is very important. Educating the doctors are very important in terms of giving empathy and sympathy to the patients. Breaking the norms, breaking the taboo, the cultural taboo that is attached, that, oh, we will be labeled as weak, we will be stigmatized, we will be labeled like being using ourselves, that, that we should not disclose. The concept here is disclosure. So, we need to break the taboo to disclose ourselves to a certain extent so that people understand what this problem is, what this disease is all about. Sometimes I feel very sad to see that cancer is given a lot of limelight, AIDS is given a lot of limelight, diabetes is given a lot of limelight, liver problems is given a lot of limelight. But where is endometriosis? I don't even see. In the Malaysian context, we talk about endometriosis to the to the ministry and etc. They are like, oh, okay, yeah, we'll look into it. We'll get back to you.
Mm-hmm. Thank you for sharing. Like this is really important, like educating men and the physicians, not just for the Malaysia, by the way, for the whole world. It's really important.
Yeah.
Yes.
So of course, as an educated woman, I can probe the doctor, demand an answer from the doctor. But let's say if I'm from a rural area, suburban area, that I might not have education or not enough of it, might be afraid of asking, what will happen to me? That's the big question, right?
Yeah.
Where am I going to get the answers? And I will be just popping out pills, and it will just, affect my hormones. It might affect me, and it might give me lots of side effect. And I might wonder why I am, from such a beautiful woman I was, and I ended up like this. And this is based on experience, because I had PCOS and I was very young. I was on diagnosis of PCOS because I delayed it, because I don't know.
Like that's
So
really hard, because like the painkillers are not the solution, because you have to find the cause. So
yes.
And like so many people don't think about that. Like it's really hard to get that awareness in your country. Like I'm a Turkey ambassador, and I think like exactly the same things, because I think we should educate people from childhood, like boys and girls. It's so important.
Yes, and that's what we are doing in Malaysia now. I'm currently in charge of this project where we need to educate young girls at school. So
Yes.
I'm leading this project of educating young girls at school. We've done one talk in school, and you'll be surprised the amount of questions these young girls had. They personally came up to me, some of us who were there, and they asked questions. I mean, I know I'm not a doctor, but the support that they needed, they were like so they were so amazed, like, oh, such thing happens, such thing can happen. Like, oh wow, miss, I have this period pain. What should I do? So I think we need to educate young girls about understanding their bodies. It's not only period pain, understanding their bodies, understanding the changes in their bodies, and being proud of your changes, and at the same time understand if the changes is causing problem. Not like
Yes.
just, oh, it's causing problem and I just keep quiet. I don't want to tell. I don't want to talk about it to anyone. I just hide it or hid it somewhere, you know, in my mind or in my heart, and I don't want to share because of that's very common in Malaysia. We don't want to talk about it. So even like, you know, when we talk to some politicians or, you know, ministers or whatever, and the reason sometimes believers is late diagnosis happen because women don't get married early these days. You know, they prolong their marriage, and you know, that's why they can't have children and etc. So the factors that they are leading, it's a lot of fallacies. I would say there's a lot of fallacies seen in what is being said because of the lack of understanding. I don't blame them. I don't blame them because they don't understand. Because it's a women problem. You know, it's not my issue. I'm a man. It's a women problem. You need to solve the problem yourself. That's how they think.
So, do you have any?
This is often dismissed. Yes.
Do you have any ongoing projects that you want to talk about, or maybe you want to share something with the audience?
Okay, the ongoing project, currently, we did a video. We actually collaborated with Malaysian Gynecologists Association, and we actually we did interviews with endometriosis patients. And it was a success where, you know, they shared their experience as an endometriosis patient, and, you know, some had children. I mean, they were pregnant, successfully pregnant, and they shared their stories. And some of them shared their problems and their sorrows and how, you know, how endometriosis affects their lifestyle, their relationship, etc. So we collected this data, and then we created a creative video, and now this video is going to be played in the Malaysian government hospitals at the waiting room. So
it's so nice.
So while you're waiting to see your gynecologist, you will see the video of this women with endometriosis, success stories, and also the non-success stories. So that's a very nice, interesting project that currently we had. And the other one we are looking at is penetrating into schools, Malaysian schools, Malaysian government schools. Of course, private school is easier, much more easier to penetrate, but we are focusing more on government school first. Because I think private schools are they are much more exposed compared to the government school students. Yeah, so we want to penetrate government schools and educate the young girls in government school from 11 to maybe 17. Yeah. About
Thank you for sharing
pain,
all of this.
about their wounds. Problem. I hope my I mean, whatever I shared did make sense somewhere or other.
It will make sense. Thank you for staying late. Like it's 1 a.m.
Yeah, no worries. You have a nice day.
You too. Have a good one.
Okay, take care. Bye-bye.
Bye.
Let's go to speak about a topic of paramount importance in the field of women healthcare, that is endometriosis. My name is Helder Ferreira, speaking from Porto University Hospital. I like to start with this hysteroscopic view of the uterine cavity during the menstruation. And why starting by this video? Because probably everything that we are going to speak afterwards start here as a relationship with this endometrial layer inside the uterine cavity. It is a common and challenging condition of reproductive age women that carries a high individual and social cost. It's the third leading cause of hospitalization in the United States, and look at the numbers, they are really impressive. 1 in 10 women experience endometriosis in their reproductive years, 7.5 years the average time to make the diagnosis since the onset of the symptoms, and the infertility is many times associated with this disease, between 30 and 50%. What are we talking about? The presence of endometrial glands and stroma in extrauterine locations. It have been identified in almost every organ of women, many locations that we are going to talk about. The research has been increasing during last years, but look at the title, endometriosis is still a challenge. We started to work on it in 2009 in our hospital. The symptoms, pain is the cardinal symptom, but also the infertility is very common, as we spoke before, and there are several reasons to explain the infertility. The distorted and contracted anatomy that we find many times in endometriosis is responsible for this infertility in many situations. Also the pain that it causes during the intercourse, and also all the diagnosis starts listening the women very carefully, then to make the gynecological exam, and many times we find situations like this, a huge nodule in the posterior vaginal cul-de-sac, and then it's easy to understand the symptoms like dyspareunia, like painful defecation, like painful micturition if the disease affects the anterior compartment. And we have to study this with good imaging to study this endometriosis pathology. We have to keep in mind that we are speaking about a multifocal disease. It's very uncommon, very rare to find it only in the bladder or in the left ovary or in the left uterosacral. We have to inspect the abdominal pelvic cavity to check for different locations. And the endoscopy, the laparoscopy, brought us many benefits in the diagnosis and treatment of the disease, because we can see better. If we see better, we can treat better. Look at this macroscopic vision of left uterosacral ligament endometriotic nodule. Indeed, if you take a look on meta-analysis and Cochrane review, the laparoscopy has been important to treat the pain related to the disease. But because it affects different organs in the pelvis, it is important to have a multidisciplinary team of a bowel surgeon, urologist for the treatment, or thoracic surgeon, and the research and fertility centers are of paramount importance in this integrated approach to endometriosis. For the surgical treatment, we must have a strategy, and we should look for the complete resection. That many times it's challenging. We need to know the principles of laparoscopy, retroperitoneal approach, using the CO2, the pneumodissection can be very helpful. We should inspect carefully the abdominal pelvic cavity, as I said, because we are facing a multifocal disease. Look, ovarian endometrioma, this big nodule on the abdominal wall that surely it's very painful. Again, a big ovarian endometrioma, several endometriotic implants. We have to inspect carefully. And then look at this, the anatomy completely distorted, the Schoplat cyst that we need to aspirate in order to keep our surgical field appropriate for a correct dissection. The appendix is a very commonly affected organ that we have to keep in mind. The diaphragm, look at these spots of endometriosis in the diaphragm that can cause the scapulodynia during the catamenion, and the bowel. The bowel many times is affected and it causes dyschezia, a painful defecation, it causes retrorrhea during the menstruation. Indeed, it can result in occlusion, and many times, look at this, we need to do the segmental resection to do it in the proper way to avoid all the complications associated with bowel surgery, because our goal should be to remove all the disease and to make a final inspection of the vaginal cul-de-sac to be sure that all the disease has been removed, because we should be radical towards the disease, but at the same time conservative towards the function. Many women look for fertility, look for pregnancy, and we have to be very meticulous and very complete in our excision approach. But there are several dangers and risks that we have to take into account. Bowel, vascular, ureter, ovarian function can be in danger, risk of fistula, ovarian failure. We have to be familiar with the ureter, that is an important anatomical landmark, with the vessels. Try to keep our surgical view clean, very dry, to keep a good vision, to be familiar with the bowel approach, and the nerves. The nerves are really important in this laparoscopic approach. We should identify them, we should preserve them, in order we keep the function, but many times the scenario is difficult. The organs are completely attached like this. But anyway, we should respect the roles. For example, here you see the beautiful laparoscopic vision of the ureter, and you go close to the bowel, making this approach step by step, slowly, without making any injury in the bowel, opening the perirectal left fossa to approach the rectovaginal area. Sometimes we need to use sealing devices like here to do our job in our endometriosis approach. Speaking a little about the bowel, very commonly affected, there are several techniques, more and less aggressive depending on the size of the nodule, if it is a unifocal or multifocal disease of the bowel. We can do only a shaving like here, or we can need to perform a resection that can be a discoid or segmental resection. For example, here, this is how we do if the disease affects the anterior rectal wall. We go for a discoid resection, but many times, unfortunately, we have to go for the segmental resection, preparing the bowel using the linear stapler in order to do the work in the efficient way to remove all the disease. We are using more and more the fluorescence ICG technique to tell us where we should cut and make our bowel resection, but also to check the anastomosis in order we decrease the risk of leakage. That is an important complication that we should avoid, because we are treating young ladies and a benign disease, and then we have to use all the strategies to reduce the risks and to reduce the complications. This is a specimen in endometriosis in opposition to oncology. We should be very conservative. We should remove the specimen as short as possible. We should be aware about the risk factors and prevention techniques of the complications of the leakage. We have worked hard, for example, in the bowel endometriosis, how to avoid hard and very tough complications. A few words about urinary endometriosis that can cause the kidney impairment in some women. Many times the ureter is affected extrinsic or intrinsically by endometriosis. We should understand why it happens, and many times we have to dissect the ureter. We have to make the ureterolysis. using the ICG fluorescence can be helpful in this approach because it shows us the ureteric pathway. But look at this, the endometriosis is surrounding the ureter, is causing the constriction of the ureter, and many times hydronephrosis is associated to that. And in the bladder, unfortunately, dysuria, pollakiuria, hematuria during the menstruation is something that can also be associated with the anterior compartment endometriosis, and we have to approach it in the proper way, like in the posterior compartment. We should go laterally, avoid to go directly in the disease, opening both paravesical spaces, and we should go more or less deep according to the infiltration of the disease. For that, it is of paramount importance the preoperative study with the ultrasound, with the MRI, with the cystoscopy. Look at this, the mucosa infiltration of the disease. The huge nodules sometimes affect this, and we have to put some double J stents on the ureters. The ovaries, I always say that ovaries are the diamonds of women, and we have to treat them very careful. Preservation is more important than complete treatment of cyst if wish to become pregnant. So we have to do this technique, the cystectomy, in the proper way, using the proper instrumentation to preserve the ovarian healthy tissue. And also we can go for sclerotherapy using ethanol in young ladies, in adolescents. There are some studies now that are in favor of this approach for adolescents. Diaphragm also, it's common, we have to be aware of it. It also can be transmural or affecting only the abdominal or the thoracic layer. Sometimes we need to be more aggressive, and we need to open the diaphragm to excise the nodules. Like in this case, you see, we are removing this diaphragm endometriosis. But we have also some situations that we need to go by thoracoscopic approach, cases associated with hemothorax or repeated pneumothorax. This is in the proper way. Sometimes we have to be radical because the symptoms persist or recur. Adenomyosis is the main reason for that, and we have to go for hysterectomy, and then we follow the steps described. Hysterectomy in endometriosis can be really challenging. Thank you very much for your attention.
Dear colleagues and friends, first of all, I would like to thank Professor Kamran Nesat for his kind invitation to be a part of this select group, surgeons, laparoscopic surgeon treating endometriosis. Let me introduce myself. I am Dr. Luis Rubalcaba. I come from Guadalajara, Mexico, the second largest city of my country. I finished my residence as an OBGYN in 1993. Then I traveled to Germany, in the north of Germany, in a small city, Kiel, to do my fellowship as a laparoscopist, along with Professor Kursen and Professor Lilo Mettler. Here, I got skills and all knowledge to do surgeries in laparoscopies. When I came back here to Mexico, that was in 1995, I started to do a lot of laparoscopic, mainly in patients who have endometriosis. Then in 1997, I traveled to US to do my residence, my fellowship as a fertility doctor, also a visiting fellow many times in Japan to obtain all the knowledge to treat for infertile couple. However, we believe that the surgery, the laparoscopy to obtain the pregnancy in our patients is our goal. That's why if we have a couple with good age, I mean the woman with good age, good ovarian reserve, and good sperm sample, we treat this couple doing laparoscopy. We are doing at the end IVF in those couple. Staying in Kiel in Germany, we receive a lot of company to demonstrate all the equipment to do laparoscopies. Since 1995, when I came back to Guadalajara after to finish my fellowship as a laparoscopist with Professor Kursen, we are doing at least 1 or 2 surgeries per day, mainly in advanced laparoscopies. I mean, some cases are so easy, laparoscopies, like ovarian drilling, like tubal adhesions, removed tubal adhesion, but mainly most of the patients have endometriosis. About our results, treating patients who have endometriosis, with or without analogous, it depends obviously the severity of the disease. We have had many pregnancies, a great pregnancy rate treating this problem. But as everybody knows, it's not only to looking for the pregnancy as well, to treat gynecological disease which affect our patients in terms of pain, pelvic pain, chronic pelvic pain, and infertility as well. Regarding our expertise, we are doing as well robotic surgeries. We are working along with the Sweden team with Dr. Mats Breiström, who achieved the first uterus transplantation and pregnancy in this patient. We are working hard to obtain the uterus by laparoscopic or by robotic, and then to do the first uterus transplantation here in Mexico. Finally, I would like to say that I am so grateful with Dr. Kamran Nezhat. For me, it's a great honor that he invited me to be a part of this select group, because I consider him probably the best in the world to do laparoscopic. For me, it's a great honor. Thank you very much.